I want to thank everyone who is joining us. Bradford hosts webinars on a quarterly schedule. We will offer 2 additional webinars in 2023, so make sure you check our website for any upcoming events. I will also include a direct link to our events page in the chat box for you to check out other scheduled events. Before I introduce today's session, I want to share some important information with you. You are viewing this in webinar format, which means that you can see the presenters, but your video and audio are off. Please either use the chat or the Q&A functions located at the bottom of your screen to ask questions regarding anything discussed or to communicate with our presenter. At the end of the presentation, we will have a brief discussion where questions are received and will be answered at that time if the presenter does not answer them during the presentation. Please note that you will receive a post-session email that will include a link to materials presented and referenced today, as well as a link to a video recording of today's presentation. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services provides continuing education contact hours at no charge to you. Your attendance and participation are being recorded through your login, so there is no need to put any attendance information in the chat box. After the conclusion of today's presentation, you will also receive an email with a link to an evaluation. The survey link will be open for 30 days post-webinar. You must complete the evaluation in order to receive continuing education credit for your participation. After completing the survey, you will receive your certificate within 2 weeks via email. Late evaluation submissions after 30 days from today will not be accepted. Therefore, continuing education credit will not be awarded in that event. Make sure you complete the survey as soon as possible. If you would like to complete the survey immediately after today's event, we will include the CE evaluation link in the chat box near the end of the presentation. We are expecting a large attendance for today's session, so your patience is appreciated regarding the education components, as we have 1 staff member that processes the evaluations and certificates. Finally, if we experience any technical difficulties today, please stand by while we do our best to resolve them. If the webinar gets interrupted in any way, we will get logged back in as quickly as possible. Now that we have the housekeeping issues out of the way, I would like to introduce our session. We are excited for today's session entitled Ethics for Professionals. Our presenter today is Ludwig. Zach is a multi-state licensed professional counselor, supervisor, and serves as the Vice President of Clinical Services and Accreditation for Bradford. He has had multiple roles within the company over his 12-year tenure and will tell you more about himself during the presentation. I hope you enjoyed the presentation, and I will now turn it over to Zach.
Thank you, Kendra. Good morning, everybody. Well, you really can't say good morning back, but it feels weird to not say good morning. I'm seeing lots of good mornings in the chat. Thanks for telling us where you're coming from. See lots of people from all over, largely in the Southeast, but welcome. Right now we have exactly 666, okay, good, just 667 participants. Oh, now it's back to 666. This isn't good, guys. We got to get a couple more people in, because that's a bad omen right there, especially on a Friday. We have a lot of people here. Welcome. I'm glad you're here. This very well might be your very first time joining us for one of our sessions. If that's the case, glad you made it. I hope you get everything you came to achieve out of this session. I know a lot of you are return visitors with us, and maybe you've even seen our ethics presentation before. We usually do this about once a year. I always try to add some things to it, so I will have some latest information that you didn't have last year. So I always try to keep it pretty fresh, and keep ethics interesting is always my aspiration whenever I do this particular session. As Kendra was introducing me, I don't like to spend a lot of time on introductions, but let me just tell you a little bit about my perspective when it comes to ethics. So I've worked for Bradford for about 12 years, and in that time I've served as a primary therapist in Tennessee, and in that time I was working with adults, adolescents, and their families And in 2016, I got the opportunity to move to Birmingham, Alabama, where I live now, and I'm part of the corporate leadership team. My title's changed a few times over the years. We get creative with titles every now and then, but my title is Vice President of Clinical Services and Accreditation. What that entails is I'm responsible for the oversight of the clinical programs across our organization. I had a slide a few moments ago about all of the different offerings that Bradford has. We operate in 5 states, Arkansas, Mississippi, Alabama, Tennessee, and North Carolina. We operate residential as well as outpatient programming for adults and adolescents. As part of my accreditation role, I'm responsible for the oversight of our state departments of mental health, as well as our accreditation surveys, which include Joint Commission and CARF, respectively. And so I come at ethics not only as a provider with multi-state licensure, so I'm cognizant of those requirements and needs to be a direct service provider to those who need mental health assistance, but also looking at it from an organizational perspective. Where does an organization rubber meet the road when it comes to best practices of ethical guidelines and policies, procedures that best benefit our not only our patients, but also serve our professional staff. So I like to talk about ethics kind of from a multifaceted area, because I will reference areas around policies and forms and best practices when it comes to making sure that you, wherever you're coming from, whether that's an agency or private practice, that you're thinking through some areas that not only have ethical implications, but also possible legal and regulatory ramifications as well. So if you haven't played along with us before, that's where I'm coming from with this. I want to reiterate a couple things that Kendra said, just because it'll be especially relevant for me. This is a 3-hour session, so we are going to be together for quite a long time, and I'm going to do the majority of that talking, but I want to hear from you too. The best way to get back with me is through the chat, which I have right in front of me, and I'm pretty good at multitasking. So I'm able to read it. So if you have a question or you have a comment, feel free to throw that in there. I will most certainly do my best to try to answer things as we go for you 700 people now who are in this room. If by chance I don't get an opportunity to answer your question or it doesn't get answered, I might have time to circle back to it at the end. So I have a lot of things I want to tell you today. I'm going to try to move through it effectively and efficiently, but this is a very wide sweeping topic, as you can imagine. So I want to hear from you. Chat at me. I'll give you a shout out if I can. If not, I'm going to keep moving on. So don't take it personal. I don't tend to take breaks. So because I know that everybody's on a different break clock. You know, you all have different needs, different times. You might have a phone call or a call of nature. You know, you can. I don't see you, so feel free to walk away. Take your phone with you. I'm not going to know the difference. Come on back, get some more information. But you know, the reason I don't do structured breaks is because I want to use your time. I want to give you everything I can give you, and also I know that when we have 718 people, y'all are going to be in and off at different times for different reasons. I'm going to let you navigate that for you. If I happen to have a tech problem, as Kendra said, we're gonna get back on as quickly as we can. You know, it's a relatively nice day out. It's a little cloudy here where I am, south of Birmingham, but we're not expecting any rain in the forecast. Knock on wood. So hopefully that means we won't all have you know, tech problems. But in case I spill my tea all over my computer, you know, we'll get back on as quick as we can. Throwing that out as a worst case scenario. Some people are asking about, let's see, Zoom is under your name. So when you registered, you know, Jayla, I see that you have a question about that. Nice to see you again, by the way, Jayla. If you got questions about registration, you know, we can deal with all on the back end. Don't worry about it too much. We have, by the fact that you are here, we have your name and your credentials recorded, and we will know how long you're here. So if by chance something doesn't work on the back end, just get with us. No big deal. Don't sweat it. It's supposed to be Friday, right? We're supposed to be in a good mood. We're going to get some CEs today. All right, let's get into it. Big sweeping topic, lots to talk about. I'm going to start by talking about some latest news developments, some new things going on. We're going to go into terminology. We have to get a foundation of what we're talking about. I'm going to define some ethical principles, terms, and talk about application. I want to talk about specific areas in this field. When I say this field, I mean substance use disorder treatment, where we have some implications of ethical needs that can somewhat be complicated because of the population and disorder that we serve. And I want to think about that and how you can apply that in your work, because I know that not everybody here works in this field. By the numbers, you just can't. With now having 730 people in here, I know the majority of you, this is not your specialty. I'm hoping we can gain some competency today, make you feel more qualified in navigating some issues in this space. And as such, we're going to talk about confidentiality. Can't talk about ethics in this space without talking about confidentiality. And if you don't know why yet, you will by the end of today's presentation, why that's so important. And at the end, we get to talk about the fun topic of dual relationships and all of those fun things that people always have interest in. So lots to do. We're going to press forward, okay? Whenever I do this presentation, as I said, I know my audience. I know not all of you work in this space. So when I think about ethical considerations for a substance use treatment provider, let's first start with finding like, well, really who even is a provider of substance use disorder treatment? And I use treatment in this sense to be a very broad term. Based on the most recent data we have from SAMHSA, which is 2021, there's always a delay getting data, as you can appreciate if you do anything with data or looking at national statistics, anything like that. 2021 is the most recent you can get right now. Maybe that'll change soon. I can update my slides. But according to this data, it says in 2021, 61 million people, that was up slightly from the year before, used an illicit drug in the past year. Very important terms there. It's used, not had a substance use disorder. They used an illicit drug, and it's a long period. It's 12 months, whole last year, right? The majority of those people were smoking marijuana. Is that a surprise for anybody? I'm not surprised. I doubt you are too. I'm going to ask a lot of rhetorical questions, but feel free to chat at me too. Marijuana is the most commonly illicit drug used, followed by, in this statistic, prescription pain reliever misuse, hallucinogens, tranquilizers, that's sedatives like benzos, benzodiazepine, cocaine, prescription stimulant misuse, that's things like Adderall, methamphetamine, inhalants, and then heroin at the very bottom. A lot of this makes a lot of sense if you've been keeping the trends and finger on your pulse of what's going on in the United States with our drug use and alcohol use problems. So, these folks are walking into your agencies, into your private practice for other presentations. They're coming to you as the marriage and family counselor because they're having stressors with their spouse or significant other. They are coming to you because they are having anxiety and adjustment issues with transitions and problems going on in their life. They are seeking assistance for their depression and their fill-in-the-blank diagnoses. The use is there. The question is, how are we evaluating that and incorporating that into the diagnostic picture and into the formulation of the needs of this person in identifying how these things might be correlated, if not cause and effect. Maybe not just correlative, maybe actual cause there. Now, when we look closer at 1 month, and this is people 12 and older, this is from 2021, 57.8% of the United States, that's about 161 million people at the time, used tobacco, alcohol, or an illicit drug in the past month. A lot of those being people who drank alcohol, again, not saying that they have an alcohol use disorder, but they drank alcohol. 54 million people using a tobacco product, and about 40 million people using an illicit drug. Again, majority of those, vast majority being marijuana. When we think about it, I want to take a minute to just really focus on drinking in particular for this slide, because 60 million Americans in the past month would be considered binge drinkers. Now that is drinking 5 or more drinks for men and 4 or more drinks for women in a sitting, a short amount of time. Sitting is kind of one of those vague terms of way too, because it's not really based on any hours, it's sitting. Now you see this highest among the young adult population, 18 to 25, and college kids or college interrupted. They're just kind of getting into that age where alcohol is becoming much more accessible to them, or they are by nature of turning 21, they're able to purchase their own alcohol, but there's a lot of cultural norms around drinking at that age, and you tend to see people who are overindulging. This is followed by, and this is according to their statistics, they lump everybody 26 years and older into one bucket. That's a really big bucket. So, how much can we really derive from that number? Not a whole lot, in my opinion. And then followed by adolescents. What we know about adolescents is that they are drinking generally, by and large, less. They are, however, shifting some of that use more towards marijuana, and that's why you're seeing so much use of the vapes and the other various marijuana and nicotine products. So there's a bit of a shift going on where alcohol is becoming a little bit less common among our youngest population, but it's still very much there. And it has expanded so much since COVID. More and more people are meeting criteria for substance use disorder, especially with alcohol, than ever was before. The amount of those cases of liver disease is going up increasingly, and this started even before COVID, but then has really blown up. So all of the various other liver disorders are also on the rise, such as hepatic liver. So it's not hepatitis necessarily caused by the virus that was received from an outside source, but rather someone drinking so much that they have a hepatic condition in their liver functioning. So someone is saying, I thought this was an ethics class. It most certainly is. I'm just trying to provide a little context. I'll move on in a moment, I promise. This is all very important because it's who are we treating? Prevalence of substance use disorder. About 46 million people age 12 or older. That's 16% of our population met criteria for substance use disorder. 29 million of those with an alcohol use disorder, 24 million of those with an illicit drug disorder. These are the folks walking into your practices, and I'm asking you, how well are you evaluating these needs? Because and I'll speak personal experience, and I know it's personal, not trying to generalize to everybody, but if it's not what we're looking for, sometimes we don't do a good job of fully assessing these things. We see what's in front of us. The person says, I'm having trouble with my spouse. That becomes the focus. Did we dig deeper and find out more biopsychosocial functioning, like drug and alcohol use? Maybe that's playing into this. Maybe the reason why they're having trouble communicating is because the guy's coming home and he's drinking excessively, and then that's causing conflict in their communication, or the wife is seeing it and or husband's seeing it, whoever's seeing it, and they're not and they're having problems with what they're seeing. It doesn't connect with their values as a couple or as a person. So dig deeper. That's the message of this, okay? Substance use disorder prevalence, 4 million people initiated alcohol use, 2.8 million people initiated marijuana use, and about 1 million people initiated prescription pain reliever misuse in the year 2021. Around 41 million people were classified as needing substance use treatment. Less than half of these adults actually are getting any kind of services, but the amount of people who get services from a specialized provider for drug and alcohol problems and mental health issues is significantly low. And one statistic that I'm sharing with you here, it says less than 6% of people. Sometimes I hear numbers that are closer to about 10%, but the amount of people who can access treatment services for anything is staggeringly low, and there's lots of reasons for that. I did a presentation in March that went in greater detail about some of these things. You can check that out on a on-demand basis. If you want to check out our YouTube page, you could look at Bradford Health Services on YouTube, and you will find information on some of our previous videos. I'm seeing some people, responding, yeah, you're asking these questions in your general assessments. Absolutely. Someone referred to them as red flags. absolutely ask you and employ some standardized measurements. Things like the uncope, can be a good. The craft is a good also short assessment that anybody can add into their practice. Because my point is, regardless of your setting, you're encountering people who need substance use disorder treatment, or maybe they're not necessarily at that point of needing formalized treatment, but maybe they're looking for exploring their relationship with alcohol or drugs. And that's a great opportunity for any mental health provider in the world. Now, today we're going to talk about a lot of general ethical issues, but I really want to especially focus on some population and setting considerations, because maybe you're not as familiar with them. Okay. Latest news and developments, hot off the presses. Do the deep, little telephonic telegraph noise there. DSM-5 text revision published last year, 2022. So this is a little old news, but in case you were not aware, make sure you update your DSM on your bookshelf. And this is the most recent revision we've had since 2013. They tend to come around every so often, 6, 8, 10 years. Some updates. So they've added a new disorder called prolonged grief disorder. And they've also added a suicidal behavior and non-suicidal self-injury. So previously those had been categorized elsewhere, but now non-suicidal self-injury, that's a very interesting diagnosis that can apply to a lot of people. Someone asked what the assessment names were. Look up CRAFT and look up UNCOPE, and there's a number of others. And I might reference them later too. Non-suicidal self-injury has a broad sweeping application that helps to classify folks based on behaviors when it might not otherwise fall into something else, like depression or other presentations. Often those go hand in hand, but this can help in prioritizing diagnoses on a treatment plan, because then you can look to this diagnosis and say, okay, what are the specific interventions we want to do for that? You want to do safety planning specific to that. You want to do, if you're in an inpatient type facility, you might want to do increased body checks to look for any new or worsening scarring or cuts. So I like that they've specified it. That's my point here. So you can have that without any other requirement for another diagnosis. That's very good, because the person might not meet the criteria. So where would you have put it before? That becomes the question. They've added in the text of the DSM more information about the context of racism and discrimination. As all codes are moving this way, as they should, because there is in medical and mental health communities an embedded discrimination and racism that can exist, because typically in the history of mental health fields, they were looking at certain conditions among certain populations with a bias. A lot of case studies in early history of this field are based on white people, nearly exclusively, white men, white women, in particular, as they developed early diagnosing, but in cultural context, might not be as applicable, or might have a different underlying meaning or cause. So it's always very important as we strive for greater cultural competency in our world. Nice to see that the DSM is doing these updates. One area in particular, as we bring attention to this field, they have the substance or medication-induced bipolar disorder. That's pretty cool, in my opinion, because always a debatable area in diagnosis is the interaction of medical and substance related issues in diagnosis. It's always kind of the chicken or the egg. Which one came first? Did the drug and alcohol cause the presentation that looked like mania, or was the mania there already, maybe more of a hypomania, but then elevated with the drug and alcohol use, just as an example? So This allows for possibly you could use this as a starting place as you explore that shifting and the bipolar disorder presentation. As someone obtains abstinence and you get a better idea about, okay, this isn't necessarily caused by the drug or the alcohol. Instead, we can now change the diagnoses to bipolar disorder 1 or 2. But it gives a good exploratory starting place. So I'm happy to see these things. Pretty cool. As I said, update your bookshelf, right? NBCC Code of Ethics was just updated just last month, May 2023. They sent this out. You can access them online. No cost for these, by the way, unlike your DSM, which is going to put you back a pretty penny. But you can look at these up online. I recommend print them out. So here's a message, and I wanted to make sure I said it because I don't know if we have any students on the line today or any new graduates, and you're just getting into your licensure journey, and that's fantastic, and we welcome you. Get yourself a good binder. And now here's what you want to have in your binder. Put the administrative ethical codes for your respective state. You can print them off your board website. Print off things like the NBCC Code of Ethics. Especially if you are going to take the National Counselor exam, you'll need these. But this is the place to compile everything you need related to your professional development and identity. All of your continuing education hours should go in there. You put copies of your test exam results. Get copies of your diploma. If you can get access to your school transcripts still, go ahead and get them. Put them in that book. You never know when you're going to need them. These are messages that are inconsistent coming from the schools, but they will help you so much if you ever choose to apply for other state licensure or you need them in relation to anything. So the more data you have, the better. These are things that you think that just because you graduated, you're never going to need them again. As somebody that's moved licensure 3 times or twice technically, they need them, and your boards will ask for them. And I'm going to talk a little bit about how compact might change that, but it's just good stuff to have. So if you're a supervisor, make your supervisees do this. If you work in the education system, if you're from a college that does counselor ed or social work ed, this needs to be an embedded practice. Anyway, back to NBCC. So these are directives. That's their little blurb from their publication. Serves as the basis for effective and just method for submitting complaints for protection of both the public and the counselors. That's what codes do. So what they've said is that the addition of core values and beliefs language to the introduction of the 2023 NBCC Code of Ethics provides certainty to the necessary work of counselors. They say that it was edited for better clarity. I never had any problem with the clarity of NBCC before, but these are the sections that they divide stuff in. Honestly, when I look at these sections, that's what I remember them being before. And I had, I couldn't get I wanted a good kind of walkthrough of like, here's what changed. Like here's what we really updated. I couldn't find a good crosswalk. If anybody can actually find a good crosswalk for me from NBCC, please email it to me. I'd be really interested because I was trying to do it myself and it was difficult. Okay, somebody asked what the difference is between NBCC and NADAC Code of Ethics. So NBCC is the National Board of Certified Counselors. So that applies for people who take the NCC exam. And NADAC is the National Association of Alcohol and Drug Abuse Counseling. I think that's the actual acronym off the top of my head. So that's specific, that would be applicable if you're going after a certification as a drug and alcohol provider, which most states have some kind of certification for that, and the states will have their own codes and ethics often, but the NADAC is the national association that oversees that certification. Hope that helped answer that question. We have Medicare recognition for counselors. Yay! I know I have a lot of social workers on the call right now. This doesn't apply to you because you've always had it, already had it. But now counselors are able to bill Medicare. This came out in December of 2022 with the Mental Health Access Improvement Act. It allows for the very first time counselors to directly bill Medicare, and it's a Part B for services rendered. Medicare is the largest healthcare program in the United States, covering more than 55 million people. And if this applies, if you're interested in doing this and you're going to pursue this, check out the FAQs on the American Counseling Association's website. They have a good kind of run through of what does this really mean and what are the times, because through that FAQ, I was able to tell you what I'm seeing here about when this is really going to come into effect. So you can start doing your research now. You can start getting ready for this, but real reimbursement and billing won't actually start until January 2024. I see somebody say team social work here. Exciting news. Well-deserved change for counselors. Thank you. I've talked to some social workers who are a little worried maybe about competition in business, but there's plenty of business to go around. And this is just good equity, I think, among the mental health providers, because frankly, there was no real reason or need why social workers could do this, but counselors could not. Now we're moving a little bit closer to baseline. Daniel has asked, and someone has said it's a good question. Any updates on 42 CFR Part 2? Well, just hang in there, y'all. We're going to get there. I said we can't do this without getting to confidentiality. We will, in good time, get to it. Oh, hi, Turner. Nice to see you. Compact. Okay. I'm going to talk about the counselor compact, because that's the one that this is really most about. But know that social work compact is in the works. It's a little bit earlier in the process than the counselor compact is right now, but there are mutterings, more than mutterings. I'm hearing real tangible work is being done to do a social work compact. So social workers, hang on the line. This is good for counselors, and it will apply to you all someday. What is this compact? What it is, it's an interstate agreement among states who all pass legislature to operate as a compact state. This will allow a counselor who is licensed and residing in a compact member state to practice in other compact member states without the need for multiple licenses. So I originally got licensed in Tennessee. I moved to Alabama, so I added a license for Alabama. Then I was going to be doing some work at some more operations in Florida, so I added in a Florida license. That requires full application, same way as if I was right out of school. I got to submit transcripts, application, fees, letters of recommendation, et cetera, et cetera. So it's not a fun process. Again, that's why I said get all your stuff organized. You never know when you're going to need it. So what will change with that is you can still do that. Someone says lots of money. It's not cheap. What might change with it, what will change? Let me stop bouncing all over my words here. What will change is that operationally, you won't have to apply for a new license in a new state. What will happen is you will apply for a privilege to practice in that state. Now, what is supposed to happen is with this compact, there will be an interchanging of information, so that, let's say I want to get a privilege to practice in Georgia. I saw someone said Georgia right there. I want to get privilege to practice in Georgia. I will still have to make an application for that privilege, but Georgia will say, oh, well, we already have access to the whole registry for everything that he's done in Alabama. He passes the background check. There's no issues with any all the stuff you have to put on your application. You haven't had any misdemeanors, felonies, misconduct, any of those things. So they'll look at that. They'll say, yep, still meeting qualifications, and we like the schooling he had. We like that he's been licensed, fully licensed as a supervisor. We will give him the privilege to practice. Unknown what that will cost. Ideally, it will be less than the cost of a full license, because it should be. That stays as long as you keep that privilege active. If I ever decided to lose my origin state license, like if I ever said like, I don't want to do anything in Alabama anymore, I will lose that privilege to practice. So that's one downside of it. It doesn't act as a full license in that it stands alone. You have to continue with your origin state. For most people, that's not as much a big deal, because what's the goal you're really trying to meet by getting this compact, privilege to practice, I should say? What you're probably doing is you're trying to serve clients in your immediate vicinity. Like if you lived in Auburn, Alabama, let's say, and you have a lot of clients that are in Georgia, and you want to do telework with them just over the border, this is one route you can go in order to serve them while they are sitting in the state of Georgia. And someone saying Phoenix City, Alabama, Columbus, Georgia, all of those, absolutely. So like this can reduce those barriers, because technically, guys, right now is if they're sitting in the state of Georgia and you're not licensed in Georgia, you can't serve them. I'm going to speak a little bit about that later, but those are the realities of the tele world we live in. So this will increase sharing of information about counselors. So one thing is you can't, if there are any bad actors, they can't like say, well, I lost my license in Tennessee. I'm going to go to Alabama and I'm going to misrepresent myself, and they'll never notice because I'll never tell them about Tennessee. Well, this will create a data sharing so that should not happen as long as it's within one of the compact states. What compact states are we talking about? Well, as of this week, this is the latest counselor compact map. The dark blue is where legislation has already been enacted. The light blue is where the legislation is pending. I have watched this map over the last year or so, slowly expand westward. It is including many, many more states. It was in May of 22, actually, that we really got the 10 states we needed to get this thing rolling, because that's what the rule is. You have to have 10 involved states. We got those. Alabama was one of them, Georgia, Florida, lots of states kind of in this side of the country. That's alphabetical order. That's not the order in which they joined, by the way. So then what happens is each state has to work on how they're going to enact these rules for them. So that's why within Alabama in the last year, we've really seen a number of changes in our ethics and administrative codes, moving things more towards the KCREP standards of the 60 credit hours rather than the lesser, because that's what more and more, that's what most states, kind of base theirs on, as well as other rules around supervision and others that are more aligned with what other states are doing. So this will probably be at least another 6 months, maybe even closer to a year. I really, I know that they're working on this, but it is largely behind closed doors process in our respective state counseling boards. And, there's always lots of things that happen with board changes. In the news section of this, if I ever have the opportunity, I like to bring in some state information. I want to go back before I get on this. I'm seeing a couple questions. What happened if you're licensed under KCREP? Okay, if you're licensed and you have less than the 60 hours, it should not be a problem because you're already licensed. This was really the bigger issue if you have not gotten licensed yet. Don't delay on getting your licensure. Okay. That's my big message to everybody, because you never know when the rules are going to change. And someone asked, how do you apply for the compact? Well, you can't yet because it's not all done, but just stand by. We will get there. Say we, like, I'm not doing it. I'm as much of a recipient of the information as you are. I'm just watching it. It'll get there, and then I'm sure there will be lots of information that goes out from the ACA and from our respective state boards on how we need to navigate this. How will billing insurance work with the compact? Hopefully wouldn't necessarily be impacted, because you will have the privilege to practice in that state. So like if your client is sitting in Georgia and you're in Alabama, and they want to bill Georgia Medicaid, Medicare next year, or like a Blue Cross of Georgia or something like that, you have a privilege to practice. You have the effective ability to serve that client. So you shouldn't run into billing problems with that. The only billing problem you might have is if you're doing things on tele, and you're not actually in the state. we don't know what's going to happen long term with the ability to bill under tele, and if it's going to be the same reimbursement rate, or if they're going to cover it at all. Some insurance companies have already started saying they are not going to cover teleservices. It doesn't typically apply to OP therapy, which I know a number of you are doing, but things like IOP are already being looked at, and some are saying they're not going to cover it. Anyway, good questions. Hopefully I was able to answer as many as I could. But I got to move on though. State legislation. Anytime there's something going on in the states that I'm aware of, I like to bring it to highlight. So here is a bill in Florida that was passed in May, just really about a month ago. So what this is, and this is the quote from the ACA, it says, this is an overly broad bill that allows payers and providers, mental health providers included, to discriminate and deny coverage or care on the basis of any moral, religious, or philosophical differences. If you read the language of the bill, it refers to this as, quote, conscience-based healthcare. When I read the bill and I read ACA's discussion of it, what it really reminded me of was a law that passed about 7 years ago. And I can't believe it's been that long. In the state of Tennessee, and I referenced those Senate and House bill numbers there if you want to look them up. But what that bill in Tennessee did was it allowed for anyone who's providing counseling or therapy services that they will not be required to provide counseling to a client with whom they have a conflict of a sincerely held principle of the counselor or therapist. So what that means is, if I don't agree with you because my religion says this and you do X, Y, or Z, I don't have to work with you. And I cannot be found to be discriminatory. There's no issues about me, not treating you with unconditional positive regard and all of those things. I cannot be held legally responsible to serve you in this case. Now, I've debated this one ever since this came out in Tennessee. I've looked at it, and here's the thing. We most certainly have bad actors in our space. It is unlikely to me that just because a law passes like this, that now someone who has been acting ethically will suddenly say, oh, so I don't have to serve these people I don't like and agree with for whatever reason. They were probably already doing that anyway. And what that means is that hopefully people were not impacted by these providers, but they very well could have been. My biggest concern with this was thinking about our communities where we might not have a lot of mental health providers. And if there is a fear that I cannot go to my counselor in my small town I live in because I am afraid that they are not going to accept me for who I am, for whatever that reason is. You fill in the blank for all of those characteristics that could be. Then I'm not going to get services. Tele has been a drastic game changer, and that I hope that those who feel that they would not get quality service or be discriminated against now have found an outlet using technology to get to a broader offering of providers. To me, though, what this is a sign of is states imposing ideas on a profession. These bills are not being passed by counselors. These are being, in some ways, pushed upon us. So it's always important to be mindful of things going on in the states as it relates to your board and your codes, because things do change and shift sometimes because of things like this. So be conscious, be mindful. Hopefully this doesn't change any of your practice. If we're acting in the best interest of the patient, it most certainly would not. Let's talk about some terminology. Here's all the things I want to try to talk about in this section. We're going to go over some definitions, some common things in this space, common infractions, and recommendations for how to act, quote, ethically. So ethics are generally looked at as the standards that govern a particular profession. So I have a code of ethics and I have code of ethics that is different slightly in Alabama, Tennessee, and Florida. I also look to my national code of ethics through the ACA and the NBCC. Social workers, same way. LMFT, same way. You can compare and contrast some of these things. There are some differences between them, sometimes subtle language differences. Doctors have code of ethics, nurses have code of ethics, et cetera, et cetera. Even though real estate agents have a code of ethics. No diss to real estate. I just think it's funny. So they are guidelines that protect the profession, the professional, the client, and society. But here's the deal: not in that order. I almost said not necessarily in that order, but I will say with certainty not in that order. The board, the code, the ethics, it is derived. Am I sure about real estate agents? Pretty sure. As someone who told me that before, who was a real estate agent, they told me that they had to take a test with it. Anyway, I'm getting off. I'm going too far in the weeds. Sorry. It is not in this order. A code, the board is responsible to protect the patient, society, the profession itself, the sanctity of whatever that profession is, and lastly, the professional. Okay, so sometimes I mention this and some people don't like when I say things like this, but the board doesn't work for you. Okay, whatever board, whatever state you're calling in from, they don't owe you anything. And that sounds really harsh. Their job is to protect the patient and the public and to keep the reputation going of quality service providers in their state. If you get a bad attitude with them, or you push them, or you think that you are deserving of something, all they have to do is say, this person no longer has a license, and you will not be able to practice. And I'm hoping, I really hope that that's not happening on any subjective or arbitrary means, but don't get on bad sides by having attitudes or pushing that you are just automatically you should have a license just because of this. If they have issue with your practice, they will err on the side of caution to protect the patients and the public and the profession. So there's my little caveat on that, my little soapbox on it. We want to educate members, we want to maintain professional accountability, and we want to improve the practice overall, right? There are common terms we hear when we talk about ethics. I'll get to that chat. That's a good comment. There are terms we use commonly when we talk about ethical principles. Non-malfeasance means do no harm. Beneficence, do the right thing. Justice is fairness or equity or equality, depending on how you want to define those. Fidelity is being trustworthy, congruent, honorable, faithful. Veracity is being honest and accurate in what we do. And autonomy is allowing people to make choices and be self-directed. Values and morals, those are individual. Values are things that you need, you desire, that you think are important, things you care about. Morals are generally society characterization of things as good or bad, right or wrong, sinful or righteous. You put things into buckets and it's usually a dichotomy. What's important is that as we work through our professional work, we work through our professional work. As we operate professionally, is we have to recognize that I as a person have different values than you do, and I might look at things as good or bad or right or wrong, and you might disagree with me. That's why we're all different. But when it comes to professional work, we have to respect the differences. And I think maybe this is what the chats have been going on about. Not going on about, I don't want to minimize it, but I think this is some of the discussion y'all are having. If you look to codes, we have to understand our values and where we fit into the fold, but we avoid actions that only meet my personal needs at the expense of clients. If I am being served by the work being done and my client is being harmed, that is a violation. And I call that morally wrong. I call that ethically wrong. We avoid posing our own values on our clients. The skill in counseling is called bracketing. I bracket my opinion, my belief about this or that I might disagree with my client about. Because in order to serve them, I have to be reflective, and I have to use my skills in order to help them to address whatever their goals and needs are pursuant to their treatment. A lot of times, the friction points we might have with clients have nothing necessarily to do with why they enter treatment in the first place. I talked, kind of about the bad actors that might exist that, have very particular views about a client's race, sexual orientation, identity, gender identity, the decisions they make. A counselor who doesn't, who quote, looks down on people who have extramarital affairs, or seeks divorce, or uses drugs or alcohol. If a counselor has those personal values and morals, beliefs, you can't let those impact the work of the client. That's the infraction. That's the problem. And I want to kind of look at it specifically in this space with drugs and alcohol. Autonomy is the word someone said. Absolutely, autonomy. Allow people to make choices, live their own life. Right. When I think about justice, which is free of bias. Even within this field, there is bias among things like the term drug of choice. What is the substance that the person is gravitating towards, uses more often? What is their drug? Do they drink alcohol? Do they smoke marijuana? What about injecting methamphetamine? What about injecting heroin? There's stigmatization that exists even among the helping community, that we look at, okay, I can work, you hear somebody might say this, I can work with somebody who has an alcohol use disorder. I kind of understand alcohol, but if somebody is using needles, I don't understand. I don't like that. I don't believe that I can help that person. Whatever it is, we put people into arbitrary buckets based on things like the drug, like the method of use. And that is showing a bias that can come off even unintentionally in what we're doing. Autonomy. Are we allowing people to be self-directive? And one area of that is with rigidity in the work that we do. And one area that can be applied is abstinence model, where someone cannot use a drug or drink any alcohol. Or are we more open as providers to exploring a harm reduction model, where someone is making progress? Because even in the text, they say it's progress, not perfection, y'all. If someone is wanting to revisit their relationship with alcohol, but they don't want to just stop drinking, but they say, I want to control it. I want to drink less. I was drinking 12 beers a day. I want to get it down to 3. Guys, that's a win. Like, we can work with that. Like, let's explore that. Because the thing is, we're letting the best be the enemy of the good or the better. Like, we really have to work in that person's stage of change and adapt our modalities, our personal beliefs. And that's often where some of this comes from, is personal beliefs. So to meet the patient literally where they are at. Non-malfeasance, doing no harm. I'm thinking about where does the rubber meet the road with practitioner burnout in this issue? There's a lot of burnout going on. I'm going to talk about it a little bit later on as we move through some more of these slides. That's a very apt area of discussion right now in the world we're living in, kind of post-COVID. It feels weird to say post-COVID because it's still out there. But for the mental health and the helper space and the medical space, it got hit really hard because of COVID. And I'm sure a lot of you on this call are personally affected. We got 816 people out there at this moment. You're feeling the pressure. Somebody says you can meet me at the beach. that's Pam. So I mean, the burnout is real, and I see this as I look around at our space. I look at it as we talk to all agencies. People leaving the workforce in mass, getting out of the helping profession in general because of the challenges we've all faced over the last number of years. Someone said harm reduction may not benefit everybody. Harm reduction may not benefit everybody, but if that's what the client's willing and able to do, let's start. Let's let them make some self-directed decisions. Always we can educate. Here's how the progression of this disease works. Here's what we commonly see. I want you to be aware of that. I want us to be cognizant of that as we move along. But we have to be willing to start somewhere, because otherwise what happens is people abandon treatment. People say, well, if I can't, I can't meet this challenge, so I'm just going to go. And that's what we don't want to have happen, right? Okay, so agencies, thinking about how we look at discharging, and we think about harm. Is it punitive based or is it non-punitive based? So, a lot of times, sadly, decisions about these can be made based on some more subjective decision making versus objective. What happened? What did we see? And so, this is an area of kind of conscious improvement always, to make sure that we are applying principles as well as policies and standard operations to the decision making that we have. And then finally, just on this list, just as some thoughts about the space, thinking about fidelity, which is keeping promises. What do we say we're going to do? If we say we're going to stick to a boundary, we stick to a boundary. If we say that everything we say here is confidential, well, you better be able to stick to that, or you better be able to inform about when there are exceptions. And if you're not doing a good job of that in your informed consent, that can cause problems down the line, especially if the patient feels that they were deceived, or that the sharing of information is not meeting their expectations. I'm going to talk through some more of that as we go. But there's lots of areas where it's important for helpers to be very consistent in their work, and sticking to what they say they are going to do. If I say that I'm going to help you because you need me to write a letter, and you sign a consent that allows me, and you want me to write a letter that gives dates of treatment and provides evidence, proof that to whoever it is, legal, employer, whatever, that you need me to give them that proof because it's going to help you to resolve some stressors in your life. If I say I'm going to write the letter, I better write the letter. If you just don't do it or fail to forget or whatever, what kind of messaging does that send to your client? It says to them that they're not important, that this is not a priority. Somebody asked if you're going to have access to these slides. Absolutely, you will. We're going to send them out to you whenever we send over the final evaluations on these. Stigmatization is very real, even inadvertently. We know that just if you walk around in this world, but even within the helping space, sometimes as providers, we fail to use person-first language. We talk about, oh, I have that session tomorrow. It's with my bipolar. I get what you're saying. You have a session with your client who has bipolar disorder, but you don't tend to say it like that. You talk about them with their diagnosis first. That exists within drug and alcohol, again, kind of with focus in on someone saying my fill in the blank substance versus the guy who happens to use inhalants. we have to focus in on the language we use, and this is a bit of a moving target. It does change. One area that I've personally seen change just in the last few years is how we talk about medication. Now we talk about medication for opioid use disorder, MOUD. Before it was more MAT, medication assisted treatment. Why that change is to emphasize that the medication in itself is treatment, is the intervention. Not medication is just an adjunct, it is the treatment. That's one of the reasons why that changed. Before that, the language of, the preferential language was something like replacement therapy. What is that indicating? Well, that's only reinforcing messages that they're switching one for the other, which is not how medication in this space works. It's just not. And we have embedded beliefs about that, somewhat driven by language that's been going on for a very long time, and some of it based on personal provider beliefs. When we talk about people are not clean versus dirty. They are abstinent, they are in recovery, they are in treatment, they are not dirty. Drug screens is another example where this comes up all the time. They had a positive or they had a negative drug screen. They didn't pee dirty. Their pee wasn't any dirtier than yours is. Was there a detectable presence of a substance that we screened for or tested for? That's the answer. So destigmatize drug screens. I'm harping on it a little bit because it hits my ear, and maybe it hits your ear. But when we all educate on this and we move a little bit closer to destigmatization, it helps us as providers. It helps our clients, and it sends the proper messaging. I know that these things take time. The drug screen example is like that. If that's the worst we're saying today, like that's much better than some of the words on this slide. As you read some of these just make me cringe. Junkie. Oh gosh. There are terms that have existed in this space for a very long time, and many of them have been abandoned. But we got to continue to move towards virtue. Our responsibility is first and foremost and always to our client or patient, whatever you say. I kind of say interchangeably, especially on presentations. Our secondary responsibility is a mixed match. It's a bag full of lots of different people. Could be patients' family members. Could be the agency you work for. Could be the agency that referred the client to you, or the court system that referred the client to you. It could be the society, could be profession, could be yourselves. Way down the list in terms of responsibility. Putting your patient first. If you put your patient first, a lot of stuff just kind of takes care of itself. I've always kind of looked at that philosophy for most operations. If you're trying to build out a private practice, or you're trying to make your agency successful, if you take care of patients, everything else will take care of itself. I promise you that. It may take a little while, but that's how it's going to work. And if you try to cut corners, and if you try to look at like, well, let's really focus in on this referral source. Let's change our practices to meet their needs above all else, even when it's not the best practice, even when it's doing a disservice. That's when you're going to run into trouble. Potential limitations here, right? So when we apply ethics, as you look to your codes, when you look to your ethical language, they have a tendency to be pretty broad and general. Somebody who writes a lot of policies, it's really hard to write a policy specific to everything that might happen. And that's the way the ethical codes work a lot too, is you have to do some broad strokes. Now, what can happen is that it might not give you the best directions about what to do all the time, and it might be open to interpretation. I'm rhetorically asking you, but I want you to think about this. Have you ever had a disagreement with somebody that had an embedded ethical implication? I know that I have, and it might be with things like Okay, I think that we've gotten to the point where we need to bring in someone else for the safety of this client. Whoever that is, could be a parent in the case of working with minors. It could be involving emergency services or referral. Uh, I'm trying to think about broad examples without being too specific, but someone else might have a disagreement and say, no, that's a step too far. That's inappropriate at this time. That is going to be a breach of confidentiality for this person. So there's lots of examples where sometimes as individuals we have different interpretations. That's one of the downsides to the way the language is that it is open to interpretation, and experience goes a long way, as does using consultative and supervisory services of other professionals to get let's check the barometer here of, am I overreacting, or am I assessing this correctly, and get some feedback on what I should do next. Our ethical codes do tend to be pretty reactive to the world rather than proactive. There's things still in ethical codes about communication via fax machine and things like that, and doesn't get so much into all of the technology space that we are now living in. It takes time to adapt these things. As I mentioned earlier, the codes and the diagnosing are being much more responsive to a culturally competent world and recognizing where we've fallen short as a world in those areas before. So again, it's coming around, but what year is it? I think it's 2023 still. I don't know. I don't know what year it is after 2020. It's all a blur. Now, there's inconsistency and variance among professions. If you look to the social work code, you might see some slightly different language than the counselor code. That absolutely does exist. I've done some crosswalk comparisons before. Not so much in the time we have today, but that is an interesting area of discussion, and kind of talking about, well, which one kind of captures it the best. We think it's fun dialogue. We can run into times where we feel like our ethical code is a conflict with organizational policy, the law itself, and requirements of outside others like funding sources and referral sources, and et cetera. And those are conflicts that have to be explored. And the codes do give some recommendations for what to do there, but it's going to be very specific to the situation. Turning a little bit of attention, I want to talk about some common infractions. I know that this data is old. It's almost 10 years old now. But it's kind of hard to find a lot of really good relevant data on infractions. Why is that? The boards don't tend to want to publish those. So a lot of what I get for these sources comes from places like HPSO, insurance provider for professional liability and malpractice for a lot of counselors, social workers, and other professionals out there. What are some violations? It mentions confidentiality here, but then what are other types of violations that you think have resulted in disciplinary action taken by a professional board? Someone's already started in the chat, said dual relationships. Feel free to throw some more out there if you want to play along at home. What are other violations that get you in hot water with the boards? Inappropriate relationships, Medicaid issues. Boards don't necessarily get involved so much in the payer issues, unless it is also an ethical violation. Sexual relationships, yeah. Thanks, Jim. CEUs, yes. Someone else has said it as well, not having your continuing education. Dating clients, treating a family member. Why would you want to? I know my family, I don't know about yours. Finances, conflicts of payment, or entering into a bartering relationship, or patient makes a complaint about services. I don't know what we're going for there. Substance abuse on behalf of the professional, sure. Client abandonment, ooh, good word, abandonment. Attending a client's graduation, that could possibly be construed as a boundary crossing. We'll hopefully have some time to differentiate crossings versus violations. Clocking more hours than worked, possibly, if the board becomes aware of that. HIPAA violation, sure. Expired or lapsed license, that's a really good one. That's pretty easy to determine too. Lack of documentation, these are all good. Socialization with clients, doing business with clients, these are all really great examples, y'all. Professional not mentally stable. That's That's debatable. Every day I wonder about that for myself sometimes. Um, Sexual relationships with supervisees. That's first mention I see of supervisees. Poaching clients. That's cool. Yeah, that can get possibly could be a problem. I don't know if it would always rise to the level. It could, depending on the nature of it. All right, those are real good. If you want to keep them coming, feel free if you want to play along. But everybody did great. This is the little bit deeper dive on the data. So as a couple said, failure to meet CEs. Come on, guys, that's why you're here. You're getting your CEs, and keep up with them. Don't fall into the audit trap of not having enough. Make sure you know what your code says about. You got to have a certain number of ethics. If you're a supervisor, make sure you're up to date on the latest stuff with supervisors, because Alabama is an example, and it looks like other states do this as well. You got to have a certain number of hours in supervision. If you're doing tele supervision, you got to have specific training in that. You got to evidence that at least one time. So there are changes that have happened in continuing education. Don't think that just because you've always had your 30, 40, whatever number of hours it is last year, that they're not going to make it more specific. As a licensee of Florida, they have very weird specific requirements that, like, every second year you have to do this, every third year you have to do this. It's a bit much to keep up with. I just do them all every year. That way there's no way I could ever miss them. Dual relationships come up a lot. You gave a lot of examples of those. Unprofessional conduct, no proper license, non-counseling related crimes, such as if you got a DUI. Some things I've been reading about is if somebody wants to make enough of a issue about you personally not paying your child support for your child, that might be something that could rise to board decision and or board's attention. And there's kind of a clause about what's the word? I'm starting to lose words already. It's a bad sign. Quality characteristics, kind of aspirational ethics, character. Is this a good character trait? And if they say that this is not a character trait, then that could be problematic. I have read that. So I have no specific examples, but I have read that has happened for some people. Disciplinary actions can be all kinds of things, from fine to having to do CEs, reprimands on your file, probation, or even revocation of license in some cases. So those are areas to be very mindful of. This is a little bit more recent data. As I said, it can be hard to find. This is from 2019. Related to claims that got to the attention of HPSO and they had to address and then close the cases. So sexual or romantic interactions with current clients, partners, or family members in about 32% of cases. Failure to practice within the boundaries of competence, 17%. Improper sexual or romantic interaction with current supervisees, 7%. Multiple relationships with a client despite the potential for client harm. That's the key of that phrase, 6%. Sexual relationships with former clients, their partners, or family members, 4%. Improper sharing of confidential information without consent or justification, about 4%. So that had been a higher number in the previous slides, and in this data in particular, it was less. So I don't know if that means it's improving over time, or if that's just the number of cases they had handled in that particular year. Some things to keep in mind. Keep your boundaries in place. It is your job to uphold the boundaries that are supposed to exist in this relationship. You cannot rely on your client to uphold the boundaries. That's not their responsibility. It's yours. Know what your state's code says. As I said earlier, go to that code, print it off, put it in your handy little binder, update it whenever it comes due, read it, know what's in it. You will be held accountable to them whether you agree with it or not. Manage client expectations. I cannot speak enough about the importance of informed consent. You should have a robust informed consent that goes over lots of areas of need, such as confidentiality, and it would be what the exceptions to that would be. What are the expectations for how they reach you? This is just one example of what needs to be informed consent. Do you use a EHR that allows for chat functioning, text message functioning, email functioning? What happens as kind of a unintended consequences of these is providers might find themselves being kind of always obtainable. That's not good for our own mental health. So if that's what you're doing, I wouldn't recommend it. But if you're going to have out of office times, do you have auto responses built into your practice, such as saying, like, if this is an emergency, dial 911 or go to the nearest emergency room. If this is a non-emergency, I will respond to your email or your chat by X time. I reply to all messages by 6 o'clock the following business day. I don't know, but set expectations. Because how many things in our world could be fixed if we just were more transparent about this is how this is going to work, so that the person doesn't say, like, my counselor abandoned me, I could never get a hold of them. Like, well, what contingency plans did you have in place? What happens if you become inaccessible because you get in a car accident or have a heart attack, God forbid? Do you have a backup plan? If you're a supervisor, if you're a supervisor and you have supervisees, it's your obligation to have, what is that backup plan? Who can get into my files? Who can pick up, the next, obligation for my supervisees and clients as well. I don't want to exclude them. It's just we don't always think about it with supervisees. I have personally had to step in to assist with supervision when a supervisor has gone dark because of medical issues and can't get to the files and have no idea the progress that supervisee has made. So it's a lot like starting over. And that's a problem for that supervisee, and distressing, of course. But if you don't share what's going on and you don't have a backup plan, that's the situation you're setting yourself up to. What is it? It's if you fail to plan, you're planning to fail. That's exactly what I'm talking about. So informed consent can have so many opportunities to set expectations, and I only gave a couple of examples. Keep thorough and accurate notes. If you don't write it down, it did not happen. As we all know, documentation is as much art as it is science. You have to be able to document enough that you are documenting the progress or lack of progress of the client and what you're doing about it and where you're going with it. If you find yourself writing books, you're going too far. If you find yourself writing one sentence, that's not enough. So you need to find that sweet spot in the middle where you are comfortable that it captures everything relevant for that client's work for the purposes of billing, other reimbursement, good ethical code, but also something that you'd be willing to sit on a stand in court and read out loud, because that is also what could happen. And when we know that, sometimes that makes people go to the other side of the spectrum and not write enough. It's a balancing act. Someone asks if I have good examples of informed consent. Here's where I'm going to send you. Look up NADAC's informed consent and NBCC informed consent, and they will give you some pretty solid examples. I might have a slide on it, but honestly, I sometimes forget everything that's in all my slides. It's a big deck. So I might get to it. If not, you can totally Google it. Know when to terminate any client that crosses your boundaries. Proper termination, I'm going to talk about in just a moment, but if you're keeping your boundaries and stuff starts to not feel right, not smell right, not look right, like, you better start documenting and making action to make things change. And this could be a lot of different examples. Lots of things going on here. One, I think the common area that people start thinking about is if your client starts presenting with that the transference and then it's not being effectively addressed, and they are obviously wanting more from the therapeutic relationship than what is therapeutically appropriate. It starts to feel awkward. That's the time. If broaching those topics is important, but then also if it's a step too far, you need to go ahead and likely make referrals in the proper way. Know when to recommend to a specialist. This is another one of those scope of practice, and we'll talk about that later when it comes to a bit of competency. What can you competently do? And you need to understand the boundary of that. And if someone is best served by someone else who has an expertise in a particular area, make those referrals. Not everybody has every tool in their toolbox. That's how the world works. That's how helpers work. We all have different focus areas, expertise, and experience and ability to use that experience effectively. Don't have such an ego that you will not make a referral because you think that you can do everything for every patient with every diagnosis. That's not how it works. Proper termination according to the ACA is listed here. I'm not going to read the entire thing, but it brings up a bit about what we talked about earlier about referring people for personal held beliefs. This speaks to it in a number of ways. It says specifically, we refrain from referring patients based solely on the counselor's personal held values, attitudes, beliefs, and behaviors. That's really where I struggle to reconcile everything that we've said, 45 minutes ago, whatever it was now. Terminating the relationship when it becomes reasonably apparent that the client no longer needs assistance and is no longer likely to benefit or is even being harmed by the counselor. This is that area that I think is rife for abuse, and that's holding people on too long. Do you find yourself routinely revisiting that master treatment plan and saying, are we making progress? Are we meeting your goals? Here's what I'm seeing. And stagnation happens in therapy. People get stuck. I'm not saying that every time somebody gets stuck, we terminate, refer, all that. No, that's not realistic. That's not how we grow. But if we continue to be stuck and we're not pressing forward, putting that patient back in the decision-making seat, there always are, but really putting them in that seat to have that conversation about where are we going and is this still working? And again, ego plays such a role, in my opinion, about why providers fail to do this. Right? We do not abandon or neglect our clients, period. That has implications for like someone who's a bad actor that is just not doing good care. But also think about the example I gave a minute ago about like if you had to shut down immediately because of a medical issue or something that has happened dire in your life, you better have a plan to address and get these patients to where they need to go. Or even though you didn't mean any malice by it, it is neglect and abandonment, and that can be problematic. So go ahead and plan. Let's talk about competency. I want to talk about a number of things in competency. Competency has lots of implications, ethically as well as practically. I want to talk about our space, my space, substance use disorder treatment. I know it's not all of your space. I want to talk about how this applies to scope of practice, impairment, as I saw a couple of people chatting about when we talked about infractions. I want to talk about how we are well and how we some specific, telehealth competence. Competency is you are engaging in professional activity only in the areas which you clearly have the ability, knowledge, training, and experience. That's straight out of the code. I ask you rhetorically, don't have to chat at me, what can you competently do? And how do you know that you can competently do that? What's the boundary of that? Some people, when you ask the question about competency, someone says, well, I'm licensed. Cool. Well, I mean, that means that you took classes, you got your degree, you made your application. Does that make you competent in a particular area? It makes you liable. It makes you professionally responsible. But I don't know if that makes you inherently competent. In fact, I would venture it doesn't. What else can you prove? Well, is it you went to a continuing education course? Okay, great. Is it that, I one time watched a 1 hour CE training on EMDR, so now I do that. That can't happen. That's not how that works. Certificates are great. Continuing education is very good. But within that, don't overextend how these things work. there are areas that we can explore under our licensure, under our current our current expertise. But there are also things that require very specific training, evidence that you can do it through supervision, observation, peer review of your work. Someone says proving competency is an ongoing process. I don't disagree with that, Jamie. Nice to see you, by the way. And it certainly can have it can change over time, especially as one masters a particular area or expands their knowledge base. So my point with competency is egos get in the way, and people want to think that they know everything and they can be everything to every client. That's going to be a problem. If you haven't run into that problem, it's going to be a problem. In this space, there's lots to know about. You know, I would say that I have an expertise in the substance use disorder field. Why is that? Well, I work in it every day. I treat clients in the space. I do lots of research on what's going on in the world. You know, I will say that that's my expertise. Now, some people might say, well, I have an expertise in it because I have a degree in specific drug and alcohol counseling. Those do exist, and there's certifications one can get and all of that. Not trying to compare and contrast the two. They're just different ways of proving knowledge, right? If you're not working in this space every day, there's a lot of things that change, and they change pretty quickly, like common drugs and trends. I gave some trends earlier as a way of kind of talking about there's opportunities here. But somebody walks into your private practice, into your office, and they're saying that they're using Delta 8. You know what that is. You might have to do some Googling. You might have to figure out, okay, that means this. And I did a presentation more on that, a couple months ago. You could look at it on our YouTube page. But there's things that come up that shift, and we learn often things from clients before it hits the major news bulletins. Somebody's using Tiana, somebody's using K2, somebody's using xylazine. Though they're probably not going to say they're using xylazine because it's just in the drugs. But if you don't know what that is, go look into that. That will be you expanding your knowledge and expanding your competence to understand how these things work. What are some, everyone should have a competency on what does intoxication and overdose look like? This applies no matter where you work, because then what I challenge you to do, if you do not already have this, get overdose reversal agents in your practice today. Yesterday would have been better, but today is just as good. Narcan needs to be in your practice. I don't care if you're a one-off and you serve two clients a week out of the church basement where they let you rent out some space to work with a couple clients of the congregation. Have Narcan. You never know when you're going to need it, and you need to know how to use it. Expanding our competency on things like medication-assisted treatment, MOUD, to use the term of the day. That is, again, an area where stigmatization has stopped many from expanding their competence because they look negatively upon the opportunities that medication affords us and patients. So if you're not familiar with these, Bradford does lots of training opportunities that certainly touch on these areas. How do other mental health conditions, co-occurring conditions, interplay with substance use disorder? Chicken or the egg argument comes back a little bit that I referenced earlier, but how do things interplay with depression and trauma and PTSD and anxiety and drug and substance use disorder? Because again, you might see the initial presentation being that mental health condition that you are working to treat, but you find that the person is also trying to self-regulate their emotions with the drugs or alcohol. How do you address that effectively in your space? You should know about suicide risk in general as a provider in the helping field, but do you understand about how that might interact correlate with substance use disorder. Your risk factors will go up. Your risk, the patient's risk factors for suicide even remain elevated once they have obtained a status of abstinent, is what the data tells us. Many people overlook that vital statistic. They say, oh, well, as long as this person remains sober, we're out of the woods. Oh, I beg to differ. The data begs to differ. We are still at heightened risk, must continue to evaluate. Other process addictions. What we can see in this space, and you very well might be seeing it in the clients you serve, is a shift from the alcohol or drug use to other compulsive behaviors. Freud might talk about sublimation, which is just, it's my favorite defense mechanism of Freud's. Sublimation would be to take on a more pro-social or society acceptable behavior. You see a lot of, especially men, they get sober and then they hit the gym really, really hard. They're like, I'm going to go all in. This is going to be my new identity. I'm going to go to the gym 12 hours a day. I'm going to take my creatine shakes. I'm going to do all of the things that make me feel healthy. And they probably do feel a lot healthier than they did whenever they were using drugs. But, then you start hearing from the family member. Family member says, you were never around whenever you were using drugs and alcohol. You were so disconnected. You were a different person. And now you're not drinking or drugging, but I never see you because you're always at the gym. So the behavior, as far as I'm concerned, looks exactly the same. Like, yeah, you look better physically, but we're still not present. We're still not a family. We still don't feel like a family. That's sublimation. Other areas that people can deflect some of this energy is in relationship, dependence on others. These codependent traits really start coming out, and it can be either relationship hopping or purely sexual relationships, where some people can be kind of quote unquote sex addict. Gambling, not just gambling in casinos. We have slot machines in our pockets constantly. Phones. You see people getting into the games. They require them to pay, just a little bit. You've got to buy tokens for this, and then what happens? They have $1,000 app bill from iTunes from Apple at the end of the month because they kept buying, and these things are so reinforcing. It's filling that gap that they got in their dopamine reinforcement from the drugs and alcohol. The apps are doing that. And they're designed to do that, and understanding that and helping to educate people in early recovery in these areas, and the families especially, is really important. So anyway, that's a whole presentation itself. I talked a little bit about that a couple months ago. Family systems. You can't work with an individual in substance use disorder treatment without addressing the family system. Operating individually helps a lot, but you have to understand the system's perspective. That's what got them here, and that's what's going to help them to heal. Are you aware of recovery resources and vernacular in your area? I saw from people who were joining in, y'all are from all over, but if you are a helper, get yourself a good Rolodex of, here's where AA and NA meetings are in the area. Here's where Al-Anon meetings are in the area. What do those mean? If you don't know what those mean, do some digging to expand your competence. You might have somebody that enters in your space wanting individual therapy, and they've recently got into recovery, and they might be going to AA meetings. They might be going to self-recovery, celebrate recovery, etc. There's lots out there, but they might start using terminology that's right out of the basic text or reference in the meetings. Do you have an understanding of some of these things? I will tell you, as a helper in this space, overlaying some of these principles of the 12 steps and the terminology helps to reinforce the messages while also coming at it from a clinical perspective. I can talk about things therapeutically, using cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing. But then when you get to sprinkle in the terminology that they hear in the rooms, it can help to validate that, okay, this person, they're speaking my language, they know what they're talking about. And if I can get in that way, maybe they'll hear me on the other stuff too. So anyway, that's one soapbox. There's a whole area. That's a whole area of interest. I think I really love talking about people who don't work in the space about some of these things, because there's so many cool things we can learn and talk about there. But I ask you about competence. You have an ability to do these things. Is it a skill, or are you actually qualified to do it? Like I don't hold, but I will seek out EMDR certification. Are you qualified to do EMDR, or other various interventions? Someone might be very well trained in cognitive behavioral therapy. That's a lot of where my basis is. That's what I really learned a lot in my education and in my application. But I've had to adapt that over time to other areas, and figure out kind of a hybridization of those skills. So where does that training and that credentialing certification fit in with your practice? Continuing education is an ongoing need. You have to always be learning. Diagnosis versus assisting. This is kind of a specific area, but I just want to bring attention to it. Like, understand what your license allows you to do, because it does differ by state. Let me give you a Tennessee specific example. In Tennessee, they currently have two pathways for LPCs in the state. You can be an LPC, or you can be an LPC MHSP. What's the difference? Well, the MHSP designation, which I happen to have, means that I took an extra exam. The extra exam is the NCMHCE, National Counselor Mental Health something. All right, I don't remember all the letters, but the NCMHCE, it's basically a test about diagnosing. And after completing that test, the board allows for diagnosing. If I did not take that test and have those letters behind my LPC, I could only assist clients. I could not diagnose them. I would basically just be a helping guide in a way, and it really cuts off the profession at the knees, in my opinion, when it differentiates these things. I think you should just make that the requirement that people should take that test if you're going to make that rule about diagnosing in the state of Tennessee. That's my soapbox on Tennessee. And then impairment. This is another one of those things about how does impairment impact our scope of practice. And impairment can mean a lot of different things. Defined generally here by the ACA as one example, but most state codes also will define this in similar and sometimes different ways. In general, what it says is you refrain from offering or providing professional services when impaired. What is impaired? Is that I'm so overwrought and distracted by things going on in my personal life that I can't focus on the needs of my clients? Is that I am in physical pain because of a physical condition that I'm not able to be present and engage with my work? Is that I am using drugs and alcohol to the point where it is impacting my ability to be present, cognizant, and just actually showing up? Is it fill in the blank with a whole bunch of other scenarios? Well, the answer is yeah, and or but. It's a very interesting area to explore, because it's hard to define in some ways, and it's sometimes one of those, like, when you see it kind of a problem. Someone asked for the slides again. Yep, you're going to get all the slides. We're going to email them out to you. It'll be in your email at the end of the day. We should assist our colleagues on identifying these things and addressing that with them. Now, look to your state code about that, because some states don't say sorry. It's okay. I didn't mean to get on you. Some state codes will specify that you don't resolve it with the person, and instead you must make a board report if you believe that someone there's a negative impact on clients due to impairment. In general, it can be defined as the diminished capacity to perform professional functions. Oh, that is just nebulous for interpretation, in my personal opinion. Because if you want to use that definition, some people might fall into that bucket who don't have any otherwise explainable mechanism for why that impairment occurs. It's one thing to say, okay, this person's using drugs and alcohol, and that's likely causing the impairment. They have a medical condition causing their impairment. What about just general competency? Does that in itself make impairment? One could make the argument. So like the ACA says, if substantial harm has not occurred, you attempt first to resolve this informally with the other counselor if it's feasible. Again, some state codes differ slightly with this principle, and they say, no, you still have to make a board report. So make sure that you are documenting for yourself, taking the intervention that you believe is necessary, and then following up with any board responsibilities relevant to your state. There will be a whole section on impairment in your state code, I assure you. As we talk about impairment, we have to talk about burnout. And I always, I already kind of talked about burnout in general as kind of the problem of our space. I want to give some differentiation between these three terms: burnout, compassion fatigue, secondary traumatic stress, also called vicarious trauma. You may have heard me talk about this before if you've been on some of our previous trainings about different areas. I'm trying to move a little quicker as I'm cognizant of time. So burnout is emotional, physical, mental exhaustion. It is actually an ICD-11 code, but you cannot get disability for this, even though it is a diagnostic code in the ICD-11, because it's classified by the World Health Organization as a, quote, occupational phenomenon. Isn't that fun that in the world we live in today, these are just kind of like, well, yeah, it just happens in this, if you work here, that just happens. Here are the symptoms: feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, and reduced professional efficacy that you cannot otherwise explain as a mood disorder or adjustment disorder or other condition. Basically, burnout, in my summation, is an imbalance of demand and resources. Too much demand, not enough resources. The resources of time, money, knowledge, expertise, fill in the blank, not enough resources. And it's associated with the situation, not the individual. It's not a moralization. It is not us saying this person couldn't cut it, and so that's why they burned out. No, this is a reflection of the system, of the machine, of the grinding that happens in healthcare in general, where it is a cost-based valuation, and it has to be achieved with the least amount of input to get the most profitable output. That's how healthcare systems work, right? So that is what results in burnout. This is a survey from 2020. It is from the Surgeon General. It says here that 93% of healthcare workers experience stress in the early part of 2020. Surprised not 100%. 22% of healthcare workers reported mild depression, anxiety, or PTSD. I'm surprised it ain't higher. 32% of nurses reported potentially leaving their positions. We saw that happen, still happening. 69% of physicians reported depression in the fall of 2020. 13% of physicians reported thoughts of suicide. And 53% of the surveyed public health workers reported symptoms of at least one mental condition in the last 2 weeks. Yeah, that's not getting any better. As someone said, nurses are leaving in droves. Here are the phases of burnout. I'm not going to read them all to you. Not everybody's going to hit every single one of these. And what's also, it's not like a stepwise, oh, I'm going to go linear from 1 to 2 to 3. No, it's going to be, I'm going to do a little dance. I'm going to go 1, 4, 3, 2, 1, all the way to 12. And it's going to build upon itself as the machine grinds. Compassion fatigue, similar yet different. Compassion fatigue is the physical, emotional, and spiritual result of chronic self-sacrifice, is the term, and or prolonged exposure to difficult situations that renders a person unable to love, nurture, care for, empathize, or otherwise be present for another person's suffering. I like to sum this one up as I'm out of S word to give. I'm out of craps to give. I'll use that word. I'm okay using that. And we all get there at different places, and it's not necessarily the same thing as burnout, which is usually a bigger picture about all of the demands we face. But this could be with a particular client, or it could be with a particular situation. We're there, we're present, we're doing, it's a lot of work to be a helper. Y'all know that, y'all feel that. It can be exhausting, draining. This is the continuous draining. Your cup just never gets refilled. You unplug, you take a little self-care time, you take a little vacation to the beach, as someone said in the chat earlier. But that's the time to replenish your cup, but it never gets all the way back up to the brim again. And that's where you're just out of cares to give. So that can have a lot of different symptoms. A lot of these can look like burnout too. There's physical, emotional, and just work-related things that we see. I know for me personally, one of the areas that I'm starting to get a little crispy around the edges is I get a little shorter fuse. I'm a little bit more direct in my language, and I start noticing it, and people around me start noticing. And for some, it's let's give them a minute, and for some, it's hey, what's going on? And we work through it, and usually that's enough to jar me out and help me get focused on what's important, right? Comparison. Compassion fatigue, again, is that caregiver's exposure to the experiences by just doing the work of helping and being there, and the work that it does take to be present. It will challenge our ability to render services in an effective manner. Compassion fatigue, according to the research, is more sudden and acute, whereas the burnout is the grind that wears you down over time. And again, a little comparison and contrast there. These will be in the slides for you later. Secondary traumatic stress, also called vicarious trauma. Use the words interchangeably often. This is where you will have, because of an experience that you hear a story from a patient, and it stays with you in the same way that almost you experienced it yourself. And it's like you start having traumatic responses to the trauma in the way that someone with a PTSD might experience. Are you having trouble sleeping, intrusive thoughts about what you were told? Does this result in you having a fearful or startled response, or even avoidance of that client or situations associated with what they told you about? And this can be so hard to pin down. We could all be listening to a story from a patient. Maybe they're telling something that they went through. We'll use an example of a car accident, and they're descriptive, and they're telling us what happened and the outcomes. And one of us might get hit with that, with an internal response to that is hard to really understand. But there's something about it that just touched us as a person in a particular way, and it stays with us. And the important thing is, not only does it stay with us, but it causes impact. I see some people talking about EMDR. All of those interventions can be very good for helping people who are starting to fall, not only patients, but also us as helpers. We can benefit from our own work. If you're a helper and you're not getting your own help, I strongly recommend it. I also have a counselor. I do better as a person when I am in counseling, and I'm sure I'm a better helper when I'm in counseling than when I'm not. There have been times in my career where I've gone without a counselor for one reason or the other, and I always do better with it. So anyway, my point is, it's an area of concern for us as individuals, as for the profession, as for agencies and employers. All right. So I saw some chats. This is, so someone just named it. It is called Shrinking. It is on Apple TV. It's a one season. I hope there'll be more. It's fun. They're all counselors, and the situations they get in it could be its own training on ethical problems. But that was a clip that I pulled off the screen, because to me, it really gave a great summary of I'm out of cares to give, and just the frustration that he was in as a helper. And if you want to check out the show, some of the things that he does in response to this feeling he's had, this frustration he's had, are really fun to watch. So that's my plug for Apple. I'll be expecting a new iPad from Apple delivered anytime now, because that's my plug. Okay. For you though, today, the practicality is there are things you can do to assess yourself. You know, we're usually not really good assessors of our own needs. We tend to, because we're in this field, put the needs of others first. And we usually think of ourselves second, or maybe not even at all. You can do questionnaires like the one I have on the screen, where it'll give you some feedback on compassion, satisfaction, burnout, and relevance of secondary traumatic stress to your work. I recommend you work with others. One thing that somebody saying that's why you take time off. Good. That's one area to help. We can be islands sometimes. Get together with others who work in this space that can provide that consultative or supervisory feedback to you. Find a mentor in the space. They can help normalize and validate so many of the things that we go through every day. And if we pull together collectively, we're going to do better to serve all of our clients all over the nation. All right. That being said, let's talk quickly about tele. I talk less and less about this. We talked a lot about it in 2020, some in 2021, but I just want to, because I know that a number of you are still doing things on tele. Look to your state requirements as to how they define telework and what you're allowed to do across state lines as it relates to licensure and the location of the patient and you. Understand the technology you are using, and that we're rife for technology problems, as I just had one myself with having to stop and unshare and all that. Understand there are risks and benefits of using tele for our work, and incorporate that into your informed consent, all right? Because every state does differ slightly in how they define this and what the competency expectations are for someone who's going to engage in either teletherapy or telesupervision. Always look not only to your state license, but also make sure that your insurance coverage is okay with it. I know I've personally asked HPSO, which I have insurance with, and they said it's fine, but always a good thing to see if just to verify. Oh, it never hurts to send an email and get some documentation. When you do a consent, so this is one example I have of consent. Here's what you want to make sure if you're doing tele, include these things. Define what you're doing over tele, identify the platform you're going to be using and the method you're going to be communicating. What are the risks and benefits of using this medium? What happens if there's a technology failure? How are you going to get in touch with each other? Alternative phone numbers, alternative methods of logging in, etc. It's always a good time to review your boundaries with social media, because something seems to happen when people are on tele, on Zoom, or doing their session remotely. Something has happened where then they want to just go out and reach us on Facebook, and they think that because we're on screen, they can interact with us on screens in other ways. One is not the same. It doesn't open the door for the others, but I've noticed that that's happened a lot more in the last couple of years. Know how you are going to respond in the event of an emergency. You need to get the physical location of where your patient is at the onset of every session, whether they're at home. Don't take that for granted. Confirm the address. You don't know if they're sitting in a McDonald's parking lot, because that's where they can get the good Wi-Fi signal that they don't have at home. Confirm the location of where they are, because you don't know if that client is going to have a medical emergency and you need to get them help, or they might say, I think I'm suicidal and I'm saying goodbye now, and then click goodbye, and you have no idea where they are. What are you going to do in that situation? Plan through these ahead of time. Review time zones differences if they're applicable. Think about the culture of using the technology, because not all of our patients are going to be as responsive to this as others. Young people in general seem to do okay on tele, and they seem to prefer it in many ways. Think about our technology nomads who, they're not as equipped about using technology in their daily life, especially interacting over Zoom. So, broach those topics, make sure that people are appropriate. That is what the code says we will do. Think about your financial policies. Are you going to get reimbursed the exact same way? As I mentioned earlier, if you're doing a pre-authorization with a particular insurance company, they may have different rates for tele. They may deny it completely. Haven't seen a lot of that happening. As I said, it's been for more of the intensive programs like IOP than the outpatient therapy, which I know the majority of you are likely engaging in. Discuss those coverage, what you're going to do though, if you cannot be reached. If they try to reach you and they can't, what happens if you try to reach them and they don't show up for their session? Is that different than if they just didn't show up to your office? Do you have a different mechanism for trying to re-engage them? And then the anticipated response time for technology. We should all be using HIPAA compliant platforms. The time of the COVID exceptions is over. Here's a very short list at the top of your screen about some options that are available. It is by no means an exhaustive list. It's just a few examples. But if you're using things like FaceTime, Google Hangouts, Facebook Messenger, or a non-professional platform of Skype, you're going to need to transition to a HIPAA compliant platform because all of those others are no longer allowed anymore. Confidentiality. Okay, this is everybody's either favorite or least favorite topic. I'm kidding. This is no one's favorite. I'm going to talk about confidentiality, though. I'm going to talk about it a broad spectrum with HIPAA, but I want to talk about specifically for this space. Bear with me if this is not your favorite thing, but it is going to be relevant, and you're going to get at least one little tip of the trade about how we communicate in this space, all right? I'm going to talk about some updates that are there. Someone was asking about updates earlier. Your wait is over. Here we go. I'm going to talk a little bit about minors here. So if you do work with adolescents, there might be some relevant things to talk about here, okay? Best practices. So as it relates to the telecommunication, get a BAA. That's going to help protect your data that you are sharing over the wire. So Zoom, I know for a fact, does a BAA. Most of the others do. That's always the problem with, like, if you ever wanted to do Facebook probably wouldn't either, but if you want to do FaceTime, Apple's not going to sign a BAA with you. That's going to be one of the sticking points with why this is not going to be HIPAA compliant. We got to have written authorizations. Written authorizations, not verbal authorizations. Under Part 2, that is not acceptable. All right. HIPAA compliance on technology is only as strong as how you've set things up. So being on a secure Wi-Fi network, having password protections on your computer and on your logins for your sessions. Do you have timeouts built into your features so that if they left the computer or you left the computer for a certain amount of time, everything locks up so somebody couldn't access your information? We must take reasonable steps to ensure confidentiality is assured. Many of our ethical problems arise out of questions about confidentiality. We always respect the dignity, privacy, and worth of all individuals and organizations involved. And we protect from unauthorized disclosures of information given in the therapeutic environment. That's straight from the codes. When we talk about confidentiality, we're talking about two things. We're talking about HIPAA, we're talking about 42 CFR Part 2. HIPAA is the Health Insurance Portability and Accountability Act passed in 1996. 42 CFR Part 2 is the federal law, and CFR, by the way, stands for Code of Federal Regulations, and there's a lot of them. Feel free to read them. They're a blast. It is the federal law and regulations that protect confidentiality of information related specifically to alcohol and drug treatment, prevention, diagnosis, all right? HIPAA from the 90s. Somebody asked what's BAA? Business Associate Agreement, but I'll also expand on that more in a minute, but thanks for keeping me honest and asking. HIPAA, wide sweeping. We talk about this in general healthcare. It has a lot of goals. It protects information, provides administrative simplification, ideally in principle. It should help to control costs because it looks to how healthcare information is shared, especially between HMOs and clearinghouses, to look at like, okay, do we have equity across our healthcare systems? And within that, hopefully providing some common best practices and best pricing, which can vary drastically, even across town, by the way. Now, privacy specific implications, which is more applicable to all of us on the call here. This applies to all PHI, patient health information, or private health information, depending on protective health information, how we want to define it. It establishes rights where a patient can access and ability to amend their information, and as I said, aspires to control costs. Part 2, as it's in short term referred to, you say part 2, I don't read the whole thing. Part 2, this is protecting alcohol and drug specific information, but there's one weird phrase in the language that says for federally assisted programs. Some people then get caught up on that and they say, well, I'm not a federally assisted program. Well, you take Medicaid, Medicare, government payer like TRICARE. If you do MOUD, which is regulated by the DEA and the feds, then you are a federally assisted program. So that's a specific about applicability, but then other language also talks in this code about anyone who holds themselves out to be a substance use disorder treatment provider, then it would apply to them as well. And that's where like sticking places like Passages Malibu, who, they're going to take private pay as an example. They might say, well, I'm not federally assisted. Well, but everybody knows you to be a drug and alcohol treatment, so it is applicable. That's the argument can happen there. Part 2 is regulated by SAMHSA. Comparatively, HIPAA is regulated by HHS, and those are some things where we're seeing some administrative simplification that I'll speak to in a minute. The thing with Part 2 is it applies for anybody that got treatment or who sought out evaluation for alcohol and drug related problems or received any preventative or education related activities related to alcohol and drug. There's definitions under Part 2. I'm not going to read those to you. They're going to be in the slides though. Have fun with that. In 2020, we saw some legal changes happen, but I will say these regulations did not directly amend Part 2 application. All right, so the CARES Act, what they did in their act, but is still kind of coming to form, is perpetual consent that's valid until it's revoked. So it stands forever. That stands in the face of kind of the principles of Part 2, which basically say for the time that it is relevant. It changes the penalties of violations. So if you have a HIPAA violation and that goes through the OCR, the Office of Civil Rights, they will penalize based on the number of occurrences of violation. Whereas Part 2 has always kind of fallen into a criminal penalty where someone could actually face jail time. Don't really ever see that happening, but what they did is they want to synthesize that so that it is a civil penalty, a financial penalty. They added in some anti-discrimination language. It reaffirms utilization in court-ordered settings, and it talks about compliance with notification that are more aligned with HIPAA, as I said, to the OCR. Some changes that did happen, they talked about reframing emergency situations. So historically, you talk about that mainly as medical emergencies, and that still stands, but some broadening about environmental hazards like natural disasters and hurricanes. Like we might have to reveal patient identifying information if I run an agency in the Florida Panhandle and I need FEMA to come get everybody out and I turn over a list. Here's everybody here, here's the meds they're on, because we need to keep these going and we're going to transport the meds with you and we're doing this handoff. I'm not going to go through and get a consent from every single patient as a hurricane is impending, looming in the skies above us. We're going to get out of there and make sure everybody's okay. So that helped to give a little bit more reframing. But even in 2020, when all these kind of quote unquote changes were happening, they still said, you have to get consents. You have to have written consent. Now, the written consents were broadened slightly. Historically, I had to have the specific name of an individual who's going to be receiving the information, but that's not very realistic if I have to send records to the Social Security Administration, which is the exact example that they use in their trainings. You can write that disclosure to Social Security Administration, as long as you write what the purpose is and what it is you are disclosing. That will meet the administrative obligation. There's a lot of debate about maybe Part 2 is too rigid, because it does have a bit more rigidity than HIPAA, because HIPAA has this ability to share information for TPO. TPO stands for treatment, payment, and other healthcare operations, and it's it allows for some more open sharing of information for those needs. Part 2 is much more buttoned down and does not allow for that. Part 2 predates HIPAA. It's been around since the 70s. And it's long been the position of organizations like SAMHSA that if we degraded these requirements, that we'd have fewer people entering treatment because they'd be nervous that their information would be known among family, employers, and the community at large. So that maybe we need to keep these boundaries, these walls up. But then in the meantime, what's happened is we've come a long way about healthcare equity and destigmatizing conditions. And you see that with things like the Mental Health Parity and Addiction Equity Act of 2008 and the Affordable Care Act of 2010. So it starts to then question, like, maybe the partitions are up and it's causing negative consequences. Like maybe the fact that we have all these walls up doesn't allow for effective communication among healthcare providers. Because guys, the problem we face in healthcare in general is coordination of care. We're not talking to each other as providers. We're not doing referrals. We're not handling all of the holistic needs of our patients. They come in and they have medication needs, they have medical needs, they have mental health needs, they have et cetera, et cetera. Collaborating and communicating among internal and external interdisciplinary teams, somebody said it, warm handoff, we're not doing a very good job about that, and we're losing that golden thread through the treatment, and that's where our patients fall through the cracks, and that's where they are harmed. So one argument is that maybe Part 2 plays into that by making such segmentation in our record keeping. So again, I don't have answers. I'm just bringing problems to the table. We know that HIPAA is going through a couple of changes already this year, and the public comment period that was open on some changes ended in March. Now, a lot of these changes, as I read them, a lot of them were talking about electronic transmission capabilities of information that we use in healthcare claims and prior authorizations, hopefully to reduce some of the resource burden on providers and removing some of the manual processes involved in, again, mailing and fax communication. So HIPAA is getting a little bit more wise and reactive to the world we actually live in. Good. But it's, like I said, that's HIPAA. Now it's likely that we're going to see more changes in HIPAA and even likely some changes in Part 2 that are worthy of watching and keeping up with. As I said, since 2020, we've had some simplification. The ability to do the release to the Social Security Administration, that was huge. That really does help. Like I cannot overplay like how much that makes for our ability to get the information the patient wants sent to where it needs to go without too much of a burden. So we're making strides. But at the end of the day, we are still here in a Part 2 world, which means that we have very specific disclosure rules, which means I cannot identify a patient either directly or indirectly, wink, wink, as having a current or past drug or alcohol problem, or participating in any drug or alcohol program, or having a consultation done to seek out, do they have a drug and alcohol problem? I can't tell you any of that unless the patient specifically gives me a consent in writing or another exception applies. I'm going to give you those exceptions now. But what I want you to hear as a provider that may not work in this space, if you call up a provider that works in this space and you ask questions about a patient, maybe even you referred into treatment. And the answer is, I can neither confirm nor deny. That is not a wink, wink, you know what I'm saying? Because that would be me indirectly answering the question. That is the only answer I can give you. Now, that answer might mean a couple of things. It might mean that I have no idea who you are talking about because I did not see them. It might mean that I know exactly who you're talking about, but they have chosen not to sign a release to you. Or it could mean all kinds of combinations like, I know who you're talking about, and oh, they failed to sign a release, or they're going to hold off on it or something. If you hear that and you have a question about a patient, go to that patient yourself. Call them up, see them at your next session and say, hey, did you go over to Bradford? Did you go over to fill in any provider? It's not just a Bradford thing. Did you go get that evaluation that I recommended for drug and alcohol? If so, are you willing to sign a consent so that I can talk to them or that they can talk to me? And then you address that on your end with them. Believe me, the provider, the substance use provider, is asking those questions on our end. Sometimes patients don't want to sign. And because of part 2, we cannot talk back and forth. If we were not in this space and we were talking strictly about a HIPAA, there could be grounds for a TPO driven disclosure to share that, hey, did they show up for their consult? Yes or no? That's the difference in the two worlds, okay? I want to talk about some permitted disclosures, some exceptions where I don't have to have a written release. Medical emergency should be pretty self-explanatory. If somebody's having a medical situation, I'm going to call EMTs, I'm going to tell them what they need to know to help that person. Reporting child abuse and neglect. Crimes on premises. If someone gets into a fight with another patient, then police can be involved. The patients involved can press charges. Now, that would need to be initiated within the organization. Sometimes what happens is you'll have police officers show up to an agency that is a Part 2 program, and they say, hey, I have a search warrant or I have an arrest warrant for such and such, so-and-so, and I know that they're here. I can neither confirm nor deny. An arrest warrant is not sufficient for me to tell you that they are here. Speaking on behalf of an organization, we have written very specific policy and scripting about how to handle that, because that is a very stressful situation to be in at best. If you work for an agency that is a Part 2 agency, I encourage you to explore that area and exactly what your counsel will inform you as to what needs to happen next. Because we don't want to just give in, but we also are trying to keep that balance of what's the potential outcome here. They could push in, and these are people with guns. And what does that show to our clients? And I don't want to re-traumatize them. I don't want to put them in harm's way in any sense of the imagination. So there has to be a practical, this is as far as we can go before we need to do X, Y, or Z, okay? And that's as much detail as I really want to give in this forum, but think through those things if you're an agency and this applies to, okay? Internal communications. We can talk within an organization that is under one covered entity umbrella, but I ask you to really consider who needs to know. There's marketing teams, there's teams that do other things that are not involved directly in patient care. They don't need to know the specifics of what's going on with the patient. They need to know enough to do their jobs and effectively manage their responsibilities. That's all. Now, qualified service organization agreements, this is also BAAs, business associate agreements, as I said earlier, or also professional service agreements, PSAs. They go by a lot of different names. Here's how this would work. I want to bring somebody out to a residential setting to do yoga, and I don't want to necessarily employ that person. I want to contract with them, and I want to sign a business associate agreements that they, as a certified yoga instructor, want to come on site, do yoga twice a week, and go home. Instead of me having to get a consent for every single patient and going through the whole, hey, what stays here, what's said here stays here every single time, I can have an agreement that has that, as well as their contracted obligations for retaining or specifically not retaining patient identifying information, and we'd have that signed, and that's a good demonstration of both parties' responsibilities for protecting confidential information and our agreement to do so. Outside auditors come in. They are under usually agreements that are signed into the contract or the care agreements. So the Joint Commission can come on site and can talk to patients and can look at records and all this stuff. That is permitted under the contract. Communication that doesn't disclose any patient identifying information, i.e. aggregate data. If I say to you, hey, the unscheduled discharge rate out of residential facilities last month was 13%. I can tell you that all day long. Doesn't tell you any patient identifying information, and it tells you something going on with the organization, right? Research, there is a whole section of ethics on research. I don't do a lot of research, but if you are going to do it, make sure that it's compliant with all of the responsibilities about consents, waivers, and institutional review boards. And then responding to a valid court order, not a subpoena. Subpoena is not the same thing as a court order. We will respond to a court order, or excuse me, respond to a subpoena in that, like, hey, we have received your subpoena, but I'm not going to release any records under a protected Part 2 program unless I am specifically ordered by the court. And it better be a valid court order, meaning signed off properly by the judge with the proper language in it about Part 2 programs and the information that they are seeking to have disclosed. Not just, I want to see all information. What information do you want to see specifically, and for what purpose? When we are releasing information, Part 2 requires that the disclosure be made pursuant to that patient's written authorization and to be accompanied by a prohibition of redisclosure. So you may notice, like if you emailed me and I emailed you back, it has a little email thing at the bottom that says, hey, if you're receiving this and you're not the intended recipient, please let me know and delete this immediately. And you cannot share that with anybody else. Because that's the other thing with these Part 2 records, they're Part 2 records. So if you get it, you can't then just turn it around and then send it to somebody else. It doesn't really become part of your record set in an official sense. It is still protected under Part 2, even if you are not a Part 2 provider. So that's a bit of a rub of it. The rule with disclosing stuff, no matter where you work, only disclose your stuff that you produce. If it's very common for my organization to get hospital records for patients who are entering drug and alcohol treatment, but the hospital discharge paperwork comes over. We look at it, we review it, we sign off on it, we put it with the record as a reference point. But if I got a court order that says I want to see all of the substance use disorder records, I'm not sending that because I didn't make it. I'm not taking responsibility for it. If you want it, you need to go to the hospital. Again, do these parameters create undue barriers? That's a debatable area. If you're sending anything out, email, fax cover sheets, whatever it is, put redisclosure prohibition information on that. And when you are distributing anything in writing, go ahead and put a copy of that consent signed by the patient, because some wording on some of these consents, the way they work is it can allow for sharing back and forth. So I might send my consent over to an external provider, but it says that it's an agreement between the two parties that the patient has signed. They have said, I am okay with sharing between these two. So they might then be able to, based on that organization's policies, pick it up and use it for then calling me back and saying, oh, hey, by the way, yeah, we got this. Yeah, they're also getting care with us, and this is what we're doing. The consent might be strong enough to support that capability. Now with minors, when we counsel minors, we are seeking the assent of the client. Assent is different from consent. Depending on the age of the minor, they might not be legally able to consent, meaning signing the actual legal, I'm legally entering into this agreement for treatment. Assent is they're at least willing enough to give it a try. Now, most young people don't enter treatment and they love being there, but they're at least saying, I assent to participating and being here, right? Because there's this balance that we have to make in working with young people about they don't necessarily always have the ability to consent or consent to receive services. And parents and families and guardians, they have rights. And we have to respect that. But we also have to keep protected information private. And we have to walk this line with them. And this next slide sums it up, I think, even better. There's a quote I found a long time ago, and I continue to use it. It says, confidentiality exists for the benefit of the client, even if he or she is a minor. Now, the way I read that, I have problems with that word, with the wording there. I think it should read, confidentiality exists for the benefit of the client, especially if he or she is a minor. Because here's the deal, gang. If you work with young people, you have a make or break situation here. This will either be because it's often their very first intersection with mental health workers, and we can either make that a positive, productive experience for them, or it can turn nasty, and then they will never trust a helper again. It's a heavy weight on us who work with young people, okay? Now, the majority of the literature will support us in that minors should be given the same confidentiality rights as adults. Now, in legal debate, that certainly can be debated. As a counselor, what I have to balance is, I can't promise that your information is going to completely be kept confidential, because there's certainly times where that could get pushed. Or there might be times where I might have to execute the exception. If I think that you're a danger to yourself or a danger to others, I'm going to have to involve others, right? So knowing that in the informed consent and talking that through ahead of time, as an advocate, we have to have discussions and in our informed consent about what's going to be productive and counterproductive with what we share about what's going on with the kids, with the parents or guardians. Someone's asking about partial custody with DHR. All of this always comes up in custody cases. Okay, that's always the thing. If somebody has, if there's a custody dispute, get as much documentation as you possibly can about who actually has custody, and get those papers. I know that's always tough. If there's a guardian ad litem situation involved, that gets sometimes easier or sometimes even more complicated. Again, we might have some more options to talk more about that, but that is a loaded area. We can get into a lot of discussion about it, I'm sure. Excuse me. It's getting to be that point. Minimal disclosure. So this is straight out of the codes, right? To the extent possible, clients are informed about confidential information and how it's going to be disclosed, and they're involved in the disclosure decision-making process. And when circumstances require the disclosure of confidential information, only essential information is revealed. That's straight out of the ACA. There is defense of providing quote unquote circumscribed information. What that means is, if I have to share some information with a parent, I will keep them informed about the therapeutic process rather than, excuse me, a full disclosure of everything that is being said. And this is defendable in law. And here are two case examples in law. The in Remark L 2001, sorry, that is a little bit more national in scope, but the Emily Holm case is straight out of Alabama. And the reference I have there is from 2019. The case is from 2018. It was itself a custody battle. And from what I can read from the ruling is that this counselor, Emily Holm, if you're on here, Emily, please shout out. I've never met you, but I talk about you a lot. She's in the Birmingham area, last I looked her up. She exerted confidentiality in the father was seeking to get information about the therapy that the counselor was providing to a child for whose parents were in a custody battle. She made a motion to quash, which is basically to ask to have dismissed the request for records, the subpoena that was received from the father. And initially the court, the civil court said, no, you have to do it. It got appealed and it went to a higher court, and they, in their ruling, upheld. They said, counselors and clients, even minors, should have the same confidentiality rights as you would expect to see in attorney-client privilege, which is a great precedent to be set, and in application has a lot of bearing in what we do every day. But we also have undercurrents that are all, that are adversarial to that idea, that are counter to this idea. And one example of this came out in 2021, the Vulnerable Child Compassion and Protection Act in Alabama. The so-called, quote, "don't say gay" law is what it's referred to in the news media. So this applies for public and private schools, and it has a wide sweeping application for counselors, nurses, teachers, principals, and other administrative officials. It says, number one, you can't encourage or coerce a minor to withhold from the minor's parent the fact that the minor's perception of his or her gender or sex is inconsistent with the minor's sex. Okay, I don't encourage or coerce. I don't coerce anybody. But the real language that I focus on here is you cannot withhold from a minor's parent or legal guardian information related to the minor's perception that his or her gender or sex is inconsistent with his or her sex. So basically, if I'm a counselor in a school system and a kid comes to me and says, "Hey, I think that I might be, I identify as female, but their sex is male." I think I reversed in my head, but my inside is not representative of what you see on the outside. That counselor cannot withhold that. So if that parent ever said, "Hey, have they ever said anything about this?" You can't say, you can't withhold anything. You have to tell them. And one could make the argument that if you want to apply this law, it means that we would have to, if I was a school counselor, I'd have to tell them. There might be a proactive responsibility that the court system could apply here. Now, when this came out in early 2021, I know that what I quote here is an email from the executive director of the Alabama Counseling Association, Dr. Nancy Fox, who's since retired, I believe. An email that she sent. She said that they were working on tweaking some of this ruling to, quote, allow counselors to do their jobs, because to me, a lot of this is contrary to my ability to work effectively with folks if there's always a conscious fear that what you tell me I have to report in this arena. This stands today. So this is the rule. And this is where we get into complexities around confidentiality, because I'm trying to uphold two principles. I'm trying to uphold the autonomy and the unconditional positive regard and the non-malfeasance and the beneficence that I want to deliver to this young person, but I'm being challenged in the law that I must do X, Y, or Z. I must tell the parent. I must disclose the thing that maybe they've trusted no one else in their entire life to say. I have to disclose that, or I face penalty. This can be very challenging, and there is precedent, not necessarily in pressing back against this particular legislature, but in other areas, we have precedents where if a counselor feels that there is good reason to not disclose something to a parent or guardian, that can be that can be taken into consideration. Consider the times when you've worked with adults that there is a real fear of punishment. I don't know if mom or dad, if they found out that this kid, felt that they were trans, gay, fill in the blank. I don't know if mom or dad found that out. I don't know if they're going to beat him up. I don't know if they're going to kill him. And I don't know if they're going to embrace him with arms wide open. I don't know. But I've heard enough kids that have said that if my dad found out, he'd kick me out, or he'd kick me worse. So this is a really, really tough situation to be in. This is something we got to seek consultation on. This is private and public schools. Someone's asking that question in Alabama. We may have grounds to breach confidentiality if we believe that someone is a danger to themselves or a danger to others, and there's precedent in there in the Tarasoff case where we get the terminologies of duty to warn, duty to protect. It's mandated when a client poses a clear and imminent danger to an identifiable victim. that language in itself can get a little squishy. I don't always have an identifiable victim. I might have a generalized statement or a indication. Where we push on that becomes the harder part. I want to talk for a couple minutes about children and child abuse reporting. So child neglect can fall into a lot of different categories. It does differ a little bit by state. Some common examples of child neglect can be inadequate clothing or personal hygiene, medical neglect, inadequate food, abandonment, failure to thrive, inadequate shelter, and inadequate supervision. Some of these terms are incredibly subjective. As you look at the code on child abuse in Georgia, and I think about inadequate supervision in particular, they actually have written out at this age, a child can be left alone for this amount of time. At this age, it can go up to this amount of time. So most states I look at don't necessarily have that language, but you need to be aware of the language of your state. There's some subjectivity that can come into this in some ways. So know what your code, what your state requires, and what your state defines as abuse and neglect. I'm going to give you some resources to resources you can take specifically if you're in Alabama, which I know many of you are. So all states require mental health workers, nurses, social workers, counselors to report to an appropriate authority whenever we suspect. You don't investigate, you don't have to confirm. If you suspect that child abuse has occurred, you must act. No time limit on reporting as long as that person is still a child. So what that means is if I get I'm going to use a different example because 19 is fraught with problems. If I get a 22-year-old that comes into treatment and they say, when I was a kid, I got abused by my father. There's no obligation to report there. The person's no longer a child. There's no child to protect. I very well might have an obligation if I suspect that this patient of mine, he tells me has a sister, and he's worried about her being abused in the exact same situation. Here's my opportunity there. Let me partner with this young adult that I'm now working with so we can protect his sister. Let's make the report together. Let's get you ownership on this one. At the end of the day, I'm going to make the report, but I'd like you to be part of the process. That's one way you can navigate that. Mandated reporting should not be delayed. You are under legal and ethical penalty to make the report. Check your state standards about where you file, but in general, you file in the county in which the child resides. If you don't know that, because maybe you're at a well, not necessarily you don't know it, but perhaps if they're away in a treatment setting that's not in the county in which they live, there may be obligations, depending on your state, to report it in the county that this kid is sitting in when you make the report. I know that sounds confusing, but some states actually do require it. I'm not quite sure why, but they do. Now, all states have a good faith immunity clause, so that if you make the report on suspicion and you're wrong, somebody can't come back at you and say, well, they violated my confidentiality, I'm gonna press charges. No, they were operating in the best interest of the child. Case closed. That's how that's gonna go. Because we're talking about this space, let's talk about drug use, specifically among that impacts our minors and our parents. Now, different states have different standards on what happens if an adult is providing, either giving or selling drugs or alcohol to a kid. That's pretty clear cut, make a report. Manufacturing drugs in the presence or premise occupied by a child. A lot of this and the subsequent couple rules here come out of the methamphetamine use, which is so toxic that it gets on everything, especially if it's smoked. It gets on furniture, it gets on clothing, and it has it's very basic and can cause burns. So manufacturing, exposing a child to where manufacturing has occurred. Some states are very specific on using a controlled substance that impairs a caregiver's ability to adequately care for the child. That in itself is some kind of squishy language. Sometimes that's where you see a lot of reaction from providers and not necessarily playing the tape all the way through. I'm gonna give you an example more of that. Now, exposing a child to where criminal sales or distribution occurs, illegal drug activity, operating in the best interest of the child, you may have grounds for report. The question always comes up in this forum and in other trainings I do. Well, what if I get a woman in treatment who's pregnant and she's using drugs? Do I have to make a child abuse report? Depending on your state, maybe, but in general, no. And especially here's two very specific languages. I'm kind of doing a counterbalance to show some difference in language. Specifically in Alabama, the training from the DHR in Alabama says DHR does not take abuse and neglect reports on unborn children. And they will tell you, if you do happen to call the reporter, the dispatch person on the other side is going to give you some information about resources so that this person can get help. In Georgia, they specifically talk about it does not require reporting, but the reporting obligation is going to fall to when the child is born. If they are showing harmful effects of the substance, then the report's made, and that's going to be more on the doctor, the nurse, the hospital, wherever it is. One thing that I think is really important whenever we talk about this topic, because this is kind of one of those knee-jerk, everybody has an opinion about this one. I like this quote that I found in 2020. It says, "Neither drug use nor having a substance use disorder is predictive or determinative of parental ability." Man, that sums it up so good. We are lumping in people who have children who use drugs as you're a bad parent. That's the messaging we are sending. And it's no wonder why pregnant women don't enter treatment, because they're terrified that they will face negative consequences just because they happen to be pregnant and happen to be using drugs or drinking alcohol. Now, there are real ramifications here, okay? And I don't want to minimize those. Neonatal abstinence syndrome, neonatal opioid withdrawal syndrome, and fetal alcohol syndrome, all of those are real. Here's my thing, though. Stigmatization is real, and we do not have equal application of our goal of protecting this unborn fetus. We have a reaction if it's drugs and alcohol. We feel we got to make a call. Well, here's my question to you, or whoever this person is. Do you have the exact same reaction if that pregnant person is smoking a cigarette in front of you? Probably should, because that's going to cause a lot of health problems for that fetus. You might want to make a report then. What about the pregnant woman who's not wearing her seatbelt? What about the pregnant woman doing this or that? Things are not applied consistently across the board. We're basing these decisions based on stigma alone and our own internal barometer that says, oh, I should do this or should do that. And that's my problem with this space. And that's why we get things like this that happen. This is from a September 2022 article in AL.com. There's a 23-year-old Gadsden woman in Alabama. She was arrested for a small amount of marijuana in her possession. She admitted that she had smoked marijuana on the same day she found out she was pregnant, which was 2 days prior to her arrest for the possession. This was in Etowah County. In Etowah County, evidently, they have a special bond condition that says she can't bail out until she enters rehabilitation treatment. Now, you also have to come up with the money to support that bond, which, if you know anything about that, that's usually like 10% of the total bond to get bailed out. So she has to come up with, let's call it $1,000. She doesn't have $1,000. And guess what? She tried to get into treatment. And according to her petition, she doesn't meet criteria for residential treatment. I'm not surprised by that. ASAM criteria, it's going to be difficult to justify marijuana automatic into residential treatment with no other criteria going on. Now, certainly the pregnancy complicates that, but the legal issues doesn't. And here's the message for everybody in the legal system. Yes, courts are mandating treatment, but if that doesn't actually connect to the reality of what they qualify for, it's not going to be feasible for them to enter that level of care. You are setting them up to fail, because they're not going to be able to get access to that treatment. They're not going to be able to show you that paper that completed treatment, and they're going to be right back in the system. There's a lot to be said of the benefits of drug courts. Drug courts, I think, have a good position here. But we have too many lawyers and judges that try to mandate things and they're getting out of their lane. Let the professionals, let the doctors and the mental health professionals assess and put the person where they need to be, where they're going to be successful. Okay, that's all. I'm getting a little off my soapboxes now. Mandated reporting. That phrase I got about DHR in Alabama does not take reports on unborn children. I took that exactly from this training that you can take. They update it every year. I take it every year. It's a pretty breezy training, but you'll give you a little certificate. You don't get CEs for it, but it's a cool thing to have in your binder. Tennessee has a pretty good DCS training. Georgia has one too. Check those out. We got to report. Like, I'm not trying to say that we don't have obligations when it's really there, but too often we have a gut reaction that does more harm than it does good, especially in the event of pregnant women. Dual relationships. We're getting towards the end, y'all. You can feel it. I can feel it. We're doing great on time, though. I'm going to talk about this last section because it has wide sweeping application. What is dual relationships? Oh, that can be so many things. Dual relationship occurs when a professional assumes two or more roles at the same time or sequentially with a patient. I like to live by the phrase, once a patient, always a patient. Once a client, always a client, whatever you want to say. It served me very well. It'll serve you very well as well. If we use this idea, we are acknowledging that as a helper, we never will lose that ability to have an exploitative role in a relationship. What I mean by that is, I learned things about my client that I don't need to know if I was their friend. Now, I might know it as if I was their friend, but the dynamic is different in the safe, confidential setting of the therapy session. Now, when we talk about dual relationships, some state codes, some national codes, they will differ in, can someone have a relationship with a client after termination? Some codes will say yes, and it might be 2 to 5 years after the last point of service. This is not allowing you to have sex with your former client. That is always not allowed. What this is talking about is like engaging in any other kind of a relationship with them. Dual relationships really can take a lot of different meanings. I'm seeing some people saying like, well, what if I'm kind of extrapolating their example that they put in the chat here, but like, what if my client happens to work at a car dealership, and I'm buying from them? That totally could happen. In general, like, first, my first blush on that would be like, first, probably get a different person to sell you the car, because dealerships tend to have more than one person. If, let's say they didn't, let's say you're like in the middle of nowhere and it's the one car dealership and it's the one guy who owner operated, and you got to have a car because yours died. You can certainly buy a car from him, but you can't get any discount just because of who you are that someone else in the general public wouldn't get. That's kind of the rule. That's actually what the government rule is related to incentives as well. Nothing that is not readily available to the public. So I like to kind of extrapolate that for my use here. You cannot be a provider and a friend at the same time. You're not a provider and a family member. That's gross. You're not a provider and a supervisor or a supervisee. That's going to be problematic. You're not a business partner. You're certainly not a sexual partner. And for our area in particular, you can't be their counselor and their sponsor or their sponsee. That'd be a weird dynamic. That'd be something to, that'd be a show maybe. I don't know. If a relationship exists, number one, we got to be transparent with our patients. So we have to say, hey, I was previous your counselor, but you're also the coach of my kid's soccer team. Does that mean that I got to pull my kid out of soccer? No, but let's set some ground rules. Like, obviously, I ain't talking about nothing that we talked about in therapy. We're not acknowledging therapy. I'm here to talk about soccer and to watch my kid get pummeled as he runs down the field with the soccer ball. Like, that's why we're here. Let's stay focused on the goals, right? That's where it's your obligation to maintain the boundary. You can't expect the coach to do it who's your former client. consult. If you work for an agency, notify your supervisor, like give them a heads up, like, hey, just letting you know, I ran into a weird situation where I went to a meeting last night and I ran into a former client who was there, and I'm just letting you know. And I didn't talk to him. I had my coffee and I did what I had to do and I got out of it. Okay, great. No problem. Document. We should all keep some what I call sidebar documentation, also more formally known as psychotherapy notes. These are things that are notes for us that are typically not included in a record set, not subject to subpoena, but I like to keep notes of things that happen as a reference point for me, because I have a really bad memory and people who work with me will tell you that. So I document stuff. So if something weird happens, I will write it down in my little binder that I keep locked up in my office, and it has always served me very well. Here's the thing. Former patients, they might need therapy again in the future. So if you like start a friendship with them down the line, well, you've now removed yourself out of the pool for being able to do therapy with them if they ever need to do it again. So you'd have to refer. And you might be a really good therapist and you might have been able to help them better than anybody else. And you've now robbed them of that opportunity. What about power differential? Really difficult to change, and they might always view you as an authority of their mental health. And I don't want to be in that position with my friends. I doubt you want to do that with your friends. It's safest to avoid social relationships with former clients, period. Client is always a client. But if you're in this predicament, you have to ask yourself these questions as part of your due diligence. Is this dual relationship necessary? Is there a risk of exploitation? Who's benefiting here? Is there a risk that this could cause damage to the patient? Is this disruptive to whatever the therapeutic relationship is? Hopefully the therapeutic relationship is in the rearview mirror. Are we really being subjective? That's where that consultation really comes in. Document your decision-making at the time as to why you think it's not exploitative and beneficial to them and hopefully to you, or else why are you doing it? And involve that patient in that decision-making. I lived and worked in small towns in my early career, and it would not be uncommon to run into former clients, or former clients were working at the restaurant I went to, or at the place where you get your tires done, or whatever it was. I have to eat and I have to get my tires fixed. So we can't live in isolation, and we are not martyrs of our profession that we cannot have socialization. But you have to be mindful of this. And this is one of those things where you see people go too far to one side of the spectrum. You see people either have wide open, loose boundaries, or you see people with very, very rigid boundaries. And there's actually some activities or some questionnaires you can take online. I've done this with some supervisee relationships before, where you can answer some questions and it'll tell you how rigid your boundaries are. Having just kind of a conscious balance of boundaries is your best hope. So, because what we want to avoid or be mindful of is crossings and violations. Okay, so a boundary crossing is a benign deviation from your standard practice. It is always for a specific purpose. It's non-exploitative. There's no risk here. So an example is, let's say I work in an agency and I finish up my last session of the day and I come outside and I notice my former client that they had left a few minutes ago before I did my documentation. They're still stuck in the parking lot and they're having car problems. I could let them get in my car. We could run down to AutoZone, switch out a battery. I give them back the lift to the office. I help them out with the battery. We go on about our merry way, right? That's a crossing. Now, nobody's getting hurt. There's no exploitation, but it's not business as usual, right? The thing is here, as soon as that's done, you return back to your normal operational patterns. So that can be an example of a crossing. A violation is there is a risk, even just a potential, that harm could fall to that client. And that is usually exploitative. It is usually only for the benefit of the counselor. And those are not allowed. Those are prohibited. The responsibility is always on you. Some examples of other crossings. with some caveats. Look to your organizational policies, look to your state standards. Some examples could be accepting small gifts. I had a patient give me a book, a daily meditative book that goes along with the AA basic text, and they gave it to me. And it was like a thank you for they were finishing up treatment. And I said thank you. And I said, here's what I'm going to do with this. This is now part of the group. I'm going to use this every day in group, and I did. And it just lived on the bookshelf right there in the group room, and we used it every day. And I was very appreciative. You have to weigh the cultural significance of accepting small gifts. It's not uncommon for someone to bake you some cookies or something, because that's their culture of saying this is how we respect what you have done for us. And so you don't want to cause undue harm by saying, oh no, I can't do that. That's against rules. That's look to your policies, but also have some common sense here. Clinician self-disclosure, too much self-disclosure. We are self-disclosing things about ourselves for a benefit. We are hoping to normalize the experience for the client, to give them a little bit of hope that, hey, things can get better because you're not the only one who struggled with this. I myself have also struggled with this. Now you have to, is that going to be necessary? Does that help? Or is this a you thing? Again, ego can be too much of a problem. Time boundaries is a boundary crossing. Ending the session right on time? Or do you find yourself with one particular client always going over? And it might be because they have a lot of needs, but are you making exceptions for them that might be a demonstration of some kind of favoritism if you looked at it from kind of the 30,000 foot view? You know what I mean? That'd be making allowances that are not typical. And then of course, unplanned interactions with a patient outside of work setting. If you didn't plan it and it happened by stance, it's a crossing because you're obviously in a different setting. The expectation is you're going to resume back to your normal operation of we only meet in the office, we only meet on Zoom, right? Receiving gifts is pretty much everything I said. Self-disclosure, pretty much everything I said. You want to avoid any appearance or actual indications of preferential treatment because we treat everyone equitably. We don't want even the look that things are not being treated equal. In a residential setting, this can kind of like bite you in the behind a little bit, because what happens is a staff member is trying to be kind. They're giving some exceptions to rules that everybody follows. Like, I'm going to give a little extra phone time to this person, or I'm going to make exceptions to our, we usually need to wait X amount of days until we do phone time, but I'm going to make an exception. Guess what? Everybody's going to see that. Everybody's going to make an issue of it. And they're going to start thinking, they must have something going on. I wonder if, ... And then that's where then the whole community starts getting in disarray. And that's where you start hearing about rumors and problems. If we're consistent, then we are sticking to our boundaries. Okay. Conflicts of interests. We don't self-refer. If you work in an agency, you don't self-refer to your own private practice. You don't enter into a business relationship with a patient or their relatives. You don't provide services to someone with whom there was a pre-existing personal relationship. And you don't sponsor or a current or former patient with whom you provided clinical services. Those are two different arenas. Absolutely no-go relationships. You do not become, quote, emotionally involved with a patient or former patient. Emotionally involved. That's also a bit of an interpretive. But what's not interpretive is becoming sexually involved with a patient or former patient, or treating a person with whom there was a previous romantic or sexual involvement. This can result in termination if you work in an agency. It can result in licensure issues. You might lose your license and no longer be able to practice ever again. Terrible consequence. Now, why do these things happen? As I'm almost to the end, I very well promise. Why do they happen? I don't believe that there's a lot of intentional malfeasance out there. I want to believe that that's not the case. And if there is, they get out of the profession pretty quick because we find them out as bad actors and nobody goes there anymore. I do think there's a degree of true naivety among new providers. They need to know the rules of the road. Supervision, consultation, that's your role. more likely we have a gradual lowering of boundaries, the slippery slope or death of 1,000 cuts, just little exceptions made over time that add up to a, oh, how did we get here? We can't overlook transference and countertransference as issues and needing more education on how we properly broach those topics with our clients. People who are inexperienced often have discomfort in uncomfortable situations. And their own egos, their need to be liked, accepted, feared, whatever it is, they're trying to please others. They take on that caretaker role. They have to be the rescuer. That's a reflection of them. So because of that, they get themselves into situations where they're crossing these lines. Maybe they're not handling their own stuff. Goes back again to that burnout and taking care of yourself. We can educate. You have to have self-awareness, seek out consultation, confront colleagues if something doesn't look right. This I got to emphasize this one. If you see something that looks weird, if something doesn't feel right, talk to the person or escalate it. Where there's smoke, there can be fire. So take proactive action if something doesn't look right. Because here's the reality of this. This can cause detriment for the patients and for the practitioners. For the patients, if we cross boundaries, they might disengage from services. They might never see a helper again. They could have distortions about their own view of self and relationships. You could traumatize them or re-traumatize them. For you, you might lose your job, lose your license, lose your professional identity. You might not, all of the colleagues that respected you might be gone. You might face interpersonal issues because now your family finds out what happens. It's not a good scene. Lastly, and you really look at these more on your own, I mentioned earlier that all the work we've been doing on tele has really eroded people's boundaries with technology. You need to make sure that you're upholding, oh, this is my work identity in technology, this is my personal identity. The code says that you have different tech presences, whether it's personal or professional, and that those are segmented, okay? Be mindful of social media, okay? Here, what social media allows all of us to do is there's a high risk for inappropriate contact with patients or former patients. They will seek you out, keep your stuff private. There's also, among providers, this self-indulgence or self-promotion that people are posting things like, be really careful what you post. Don't be posting like, oh, had a really hard day, every day is a struggle to come in. It's like, what if one of your clients somehow sees that and they're like, am I the trouble? Wow, I didn't, that I was inconveniencing you so much. I'm very sorry, but what messages are you sending out to the world? Even that's not your intention, but what does that say? You're responsible for the content on your page. So don't go liking people or things or topics that you don't agree with or could be conflict with your own ethical standards or beliefs. Set up your own rules on who you friend, who you connect with. Be mindful about who you promote. Be careful about what you share. It will reflect on you and your practice. Ethics, as we get right at the end. Continuous active process. These are standards, but they're not necessarily equipped with it. They're not directive in many senses. There's lots of areas of discussion, debate, and we've had some of that in the chat, and we've had some back and forth, and I appreciate that. Every situation is unique. You have to be able to apply broad concepts to the individual with always the focus on who's benefiting. Are we benefiting the client? Are we not causing harm? Are we assisting them? If we're doing that, you're likely doing a pretty good job. If you keep the patient in the forefront, then your focus is in the right place. Okay, we're getting to the end. I don't know if we necessarily have a lot of time for questions or discussion. I'm sure a lot of people have to jump away. It's been a very long time. I want to turn over to Kendra, though. I think that she's going to close us out on any last minute things we need to be mindful of. And also reference that in the chat, we have given you the link for the evaluation, but we're also going to email that to you as well. Maybe I missed the mark. Is there anything else? Thanks
I
for all
don't
the-
think so. I do
Thanks for
think
all
that
the-
we ran out of time though for additional questions.
That
Um,
happens with me, doesn't it?
Yeah. Thank you again for a great presentation and discussion, and to our attendees for your engagement. This does conclude today's sessions. We have now posted the evaluation link in the chat box. You'll have to scroll back a bit to find it. Please remember to be on the lookout for the post-session email with materials from today's presentation and survey link to complete the evaluation for your CE certificate. The survey will need to be completed within the next 30 days in order to receive your continuing education credit and receive a certificate. We hope you can join us for future topics scheduled later this year. I hope you all enjoy the remainder of your day.